Okay, so you're
Do you have me with video?
no, but I can start your video. There. So it has your name on it. So
Thank you. Oh, okay. I don't even need video then. If he's going to know it's me, I'll just for now. Oh, and then it restarted itself. It said Zoom quit accidentally or yeah, but I shouldn't be able to do that. If other people are able, then if hi.
I just wanted to test it out.
Let me just make sure my sound is good.
Okay. Can you hear me okay? Oh wait, am I on mute? Can you hear me okay?
I can hear it. I can hear you. Can you hear me?
Perfect. Okay. Let me make mine. Is that the case of
took the reins.
So Dr. Perry, you're all set as a host right now.
Okie doke. So will I need to let people in?
And no, everybody will
So they
be
can
on.
automatically get in?
Yeah, yeah.
Perfect.
They'll just all be automatically muted as they come in. You're frozen.
I'm what?
You're frozen on your side.
I'm frozen? Why am I frozen?
There you go.
Hey, guys.
Good morning.
How are you, sir? Hey, how are you?
All right. I'm not frozen like you are. How are you? I'm just teasing you, by the way. You are unfrozen now.
I don't like this technology.
You'll learn to love it. It'll connect you to more people and you'll love it. Says the guy that runs EEG machines, which is the most cryptic technology on the freaking planet. Okay, maybe not the most cryptic, but it's up there.
The EEG technology is easy.
Attack me. We've been reading that
This is
monstrosity. All right, I'm gonna go grab some more coffee. I'll be right back. Any objections? Okay.
Mary Ann, right back?
Sorry. Will all the speakers be able to just share their own screens?
Dr.
they're
Perry,
talking.
you'll just have to make them a co-host whenever
Okay.
they're ready to go, kind of thing.
Oh, sweet. I guess something will just come up and ask me if I'd like to make them a co-host.
You might have to, let's see. If you hit participants and then it'll pop up on the right side, you'll hit more next to their name and you can make
Okay.
make them a co-host.
Can I do that now or do I have to wait until
No,
it's
you can
time?
do it now if you want.
All right, perfect.
Just want to make sure he's in.
Mm-hmm.
And are we taking any questions at all from the group, and how are we going to be doing that?
People
Yeah,
are going
if-
to ask questions in the chat.
So we'll do them after each talk. Is that okay?
Yeah, that's fine. So you don't have
Okay.
to come back later today. Let's see. So that does not seem to be an option.
Let me make.
Everybody should be happy to hear my husband is not on the roof right now.
Yay!
Try it again, Dr. Perry.
Okay, yeah, now it's showing up.
Okay, cool.
Co-host.
Right.
Just your computer goes in, it's just like, maybe it's an version.
Switch it to the new computer. Let's go to this computer. Well, this, I don't need it now, but we're gonna be on this one anyway.
Yeah, yeah.
This I'll use for my other stuff then. I'll close this, use it for Facebook.
Scott, are you okay if I try and just share my screen to make sure everything is working?
Yeah, go for it.
Aw,
Trying to get to, hold on a sec. Everybody can see that okay?
yep.
Yep.
Perfect. Okay, I'm going to stop sharing then for now.
Okay.
Mine works too.
And so the questions, Scott, are you going to be looking in the chat and you'll just ask them, or shall I look in the chat, or what's the
No,
best way to do that?
I'll look in the chat for you and
Perfect.
I'll select a few of the most difficult, ridiculous questions.
Thank you. Appreciate that.
Yeah, just because it's fun.
Did you need to start that?
No, I'm just
Oh,
looking.
okay.
see.
Yeah.
So
And then
there's
you
only a
live
couple
like
of
this.
patients in there so far because everybody else, it looks like. I see these are all speakers and we have the Zoogenics people here.
I'll give it just a few more minutes. We'll start a couple minutes late, just to give everybody a chance to log in. Brad, did you desire to make any announcements or anything before we start?
Normally I would introduce, but I think you can do that yourself probably, right? I mean,
Sure.
okay.
All
I'm
right.
just gonna watch. I'm a spectator
right.
this time.
Sit back and enjoy the show.
That is what I plan on doing.
All right. Well, let's go ahead and get started because we've got about 4 hours worth of exciting content this morning. So good morning to everyone who is joining us virtually for Epilepsy Awareness Day, Disneyland. I'm Scott Perry, I'm Medical Director of Neurology at Cook Children's, and will serve as your host today. This symposium was put together with the help of Tracy, Dixon, Salazaar, and as I said, we've got a great lineup of speakers for you today. The topic today, as you know, is getting there, the path from diagnosis to cure for rare epilepsy. And the way the program is set up is we'll be talking about what is the difference between having a syndrome and having an etiology of the epilepsy itself. And then we'll go into why that matters and what the differences are by using Lennox-Gastaut as a wonderful example of what a syndrome is. And then we'll use Dravet syndrome and its most common etiology as an example of where the etiology makes a difference. We'll then have some great talks from those in the genetics field to discuss how genetics plays a role in getting to these etiologies, and then get some talks from advocates in groups to let you know how to get to the right care and how to get to your right advocacy group to help you get the best care. So let's go ahead and get started today. Our first speaker today has a bio that is much longer than the one she provided me. She's an outstanding speaker. Dr. Lange is joining us today. She is the professor of neurology and the director of pediatric epilepsy at the Mayo Clinic. She's a co-chair of the Nosology Commission for the International League Against Epilepsy, and finally is a member of the Medical Advisory Board of the Dravet Syndrome Foundation. So Dr. Worrell is here today, again, to talk to us first and foremost about understanding the difference between the syndrome and the etiology. So thank you for joining us this morning. The floor is yours.
Thank you. Can you see my slides okay?
Yes, we can. We can see.
Perfect. All right. Well, thank you very much for joining. I must say, we're kind of getting used to virtual meetings, but this one is particularly disappointing that it's virtual. I think it would have been fun to be in Disney. So I'm going to be talking a little bit about epilepsy and really addressing, what is a syndrome versus what is an etiology, and how does it help to actually know syndrome and etiology. So we'll start with a brief overview. So I'll address really how we think about epilepsy and walk you through the more recent classification that was approved by the International League Against Epilepsy, which I think really helps us as clinicians understand, these are the things that we really need to be thinking about in making sure that we provide the best care. What are the causes of epilepsy and how often is a cause found? What is a syndrome? And similarly, how common is it to identify a syndrome amongst persons with epilepsy? And then most importantly, how might knowing the cause of epilepsy or the syndrome actually help in choosing the best therapy? So this is a summary of the classification of the epilepsies. And this was a document that was approved by the International League Against Epilepsy back in 2017. And I think really helps me as a clinician understand these are the things I need to be paying attention to make sure that I'm providing the best care for patients. And so we'll walk through each of these levels, looking at the top, different seizure types, epilepsy types, epilepsy syndromes. And then I think at all of these levels here, we're really thinking about two things. We're thinking about even, at the time you present with your first seizure, what is the cause of the seizure? That's something that most families really ask when I first of all see their children with seizures. And then very importantly, as we know, epilepsy is not just about seizures. There's a lot of comorbidities that we need to be paying attention to. The learning issues, mood disorders, depression, ADHD, autism, a lot of things that we need to be paying attention to as well. And I think this classification really reminds us that we need to be thinking about that again with any child that we see with seizures. So we'll start at the top here with seizure types. And seizure types are really divided into two big groups: the generalized seizure types, which means that the seizures really start from all over the brain at one time, versus focal seizure types. And generalized seizure types are divided into two groups. So those with abnormal movement, or what we call motor signs, and that's things like tonic-clonic seizures, or the tonic seizures, or the drop seizures. And then those without motor signs, which are predominantly various types of absence seizures. And then focal seizures start in one part of the brain, and they can present with what we call motor movements, or twitching movements, or stiffening. And as well, we divide focal seizures into whether there is altered awareness or whether the person is completely aware during their focal seizure. And then moving to the next level, epilepsy types. So this is pretty easy. If somebody has only generalized onset seizures, this is a generalized epilepsy. If somebody has only focal onset seizures, this is a focal epilepsy. And I think one of the things this classification did is it really allowed us to understand that there are people that have both generalized as well as focal onset seizures. And we know that that's true for many early onset challenging epilepsies. Things like Lennox-Gastaut syndrome and Dravet syndrome are good examples. They can have both generalized onset as well as focal onset seizures. And so that's a generalized and focal epilepsy. So moving on to causes, etiology, and that's shown here over on the right side. And you can see here that there's a number of different categories for the different causes. And so we'll walk through each of those. So one of the questions that, one of the first questions that really comes out when I see children with new onset epilepsy from the families is, what has caused this? And that is seen really from the get-go. And that is also seen when I'm seeing patients, for example, as a third or fourth opinion who have challenging epilepsy and the cause may not be known. So what has caused this? And when we think about cause, we really divide that into the 5 specific types of causes, the 5 groups, and we'll go through each of those. And as well, there's an unknown group. So sometimes, despite our best efforts at looking, we cannot find the cause. So the most important, or the most common group, it's not most important, but the most common group are the structural causes. And that implies some type of an abnormal brain structure. And typically we can identify that based on an MRI scan. Sometimes you can also see that on a CT scan. And this is actually the most common group of known causes. So if we took, everybody who had epilepsy and tried to divide them up, the structural group accounts for the greatest number where we can actually find a known cause. And that accounts for more than half of epilepsies that begin in the first year of life, and more than a quarter of all epilepsies that begin in childhood. And when we think about structural causes, we really divide those up into two groups. So the first group is where you actually have a brain that has developed abnormally. And we can see that in this picture at the top here. This is called double cortex, where we actually see along here a second little line of cortical structure that occurs underneath the normal cortex. So this is a specific type of cortical malformation. There's cortical dysplasias. So this is where the brain has actually developed abnormally. And typically these abnormal areas have increased excitation and so predisposes to seizures. You can also have a structural cause that is superimposed on a brain that had been developing normally, but then sustains some type of an injury. So somebody who sustains a significant head injury, somebody who's had a brain infection like meningitis or encephalitis or an abscess, somebody who has a brain bleed or a stroke, somebody who's had a tumor. And that's shown in the bottom part here. So this was a brain that was developing normally, and then there was decreased oxygen and blood flow that affected the entire brain, but you can see here more prominently in the frontal area. So this is also a structural cause, but this is one that is superimposed on a brain that was developing normally. So why is identifying a structural cause important? So I just wanted to share with you this case. This is an 8-week-old girl, and she had onset of seizures on day 9 of life. And her seizures were focal seizures. She had a right head turn followed by left-sided jerking. And so you might say, well, that sounds like a focal seizure, and that's what we thought too. She was started on phenobarbital. But then at 8 weeks of age, she developed a new seizure type that was consistent with an infantile spasm or an epileptic spasm. And at that time, she was referred to our center. And here was the EEG during an actual seizure. I know you guys are not EEGers, but just let me point out, and we can see here that this is a spasm here. This was also a spasm here. And you can see that these deflections here were more on the right side when she had a spasm than on the left side. So her seizures looked focal. Her spasms, when we saw them, really looked like they were also coming from a single spot in her brain. And this was her MRI. And what we see on her MRI is there was an abnormality over here on the right, what we call frontal temporal region, that was the same area where we saw the EEG change. So right in this little area here, you can see this area is sort of darker than it should be. And you see it is not there on the other side. So we started her, because of her infantile spasms, we started her on a medication called vigabatrin, and that led to seizure freedom. And with that seizure freedom, we really saw her development progressing quite nicely for about 4 months. Her seizures, however, despite vigabatrin, recurred. These were focal seizures. They were occurring many times a day. And with those frequent seizures, she had significant regression in her development. So she had looked pretty normal up until that time. And then she really started to lose those developmental milestones. And her seizures persisted despite trials of levetiracetam and oxcarbazepine. So she has now been through 4 medicines and continues to have seizures. And so at that point, because we knew that her seizures really were arising from that one spot, we took her to epilepsy surgery. She had a right frontal resection. And this is her 3 years later. You can see how beautiful she looks. She has been seizure-free since the surgery, and her development has really blossomed, and she's doing very, very well in preschool. And I would say that, had we tried, another 5 or 10 medicines, I don't think her seizures would have been under control, and I think she would have continued to lose skills. So you can see here that knowing the cause in this situation was super important, because that allowed us to take her to early surgery. So some take-home points here. We know that focal brain lesions, particularly if they occur early in life, they often result in drug-resistant epilepsy. And if you're having very, very frequent seizures and you superimpose that on a brain that's really supposed to be developing and learning, that can really lead to significant cognitive and learning challenges as well. If you have a child who has what looks like a focal brain lesion and is not responding to seizure medicines, we really want to see that child early on for epilepsy surgery. And successful surgery not only improves seizure freedom here, but can really markedly improve developmental outcome. So let's move on to genetic causes of epilepsies. And we are really, I think, understanding a lot more about the genetic factors that lead to epilepsy. And this is, I think, an increasingly expanding field. So if we think about genetic causes, I really put those into 3 buckets. So the first is what we call genetic structural causes. And here is where you have a gene that changes the way that the brain develops. So a gene that is associated with specific abnormalities of brain development. And so if you do an MRI, you'll see that there are changes in the brain development, but that really is due to a genetic cause. And a good example of that are children with tuberous sclerosis complex, where we know that that's a genetic condition that leads to structural changes in the brain that leads to epilepsy. So that's what we call genetic structural. Then there's a genetic metabolic group. And these are genes that are associated with an underlying disorder of metabolism, a way that the brain actually breaks down nutrients to give rise to vital compounds that it needs to be healthy. An example here would be a creatine metabolism disorder or a glucose transporter deficiency. And then we also know that there are just plain old genetic, so without changes in metabolism, without structural changes, just plain old genetic causes. And these are genes that are associated with neither of the above. And there's a very, very long list of these. Many of them, particularly that cause challenging epilepsies very early in life, are what we call de novo. So these are new changes that occur in the child that are often not present in either family, either parent. And you can see here sort of the expanding genetic knowledge that we have about epilepsy. So looking at the bottom here is the timeline, and even looking back sort of, to the beginning of our current millennium here, around 2000, you see we understood a little bit. There were a few genes that we understood, and importantly, SCN1A was described there. But look what's happened in the last 10 years with our understanding of next generation sequencing. And we see this marked increase in the number of genes that we now know are associated with epilepsy. And I think if I came and talked to you next year, there would even be larger numbers on this list. So we know that genetic testing is really important in early life epilepsies. And the Pediatrics Task Force of the International League Against Epilepsy has indicated that standard care should permit genetic counseling by trained personnel. So this is something that should be expected in the provision of care for a child with epilepsy. And how commonly do we actually see genetic changes in persons with epilepsy? This was a nice review article put out by the group in Boston, and they looked at all of the articles that had come out that showed what was the yield, so the proportion of patients who actually had a positive result who actually had these tests. And obviously that's going to depend a little bit on the type of epilepsy that you look at. But overall, they found an average yield for something called a chromosomal microarray, which looks for little bits of extra or missing pieces, about 8%. For an epilepsy gene panel, and this is looking for a number of different genes that can be associated with epilepsies, about 23%, so almost 1 in 4. And then whole exome sequencing, which is a more detailed look at at all of the chromosomes, about 45%. So you can see here, these are pretty high yield tests. And certainly in early onset epilepsy, I think these are close to our yield from MRI. Well, how about in adults? We know that there's a lot of adults that are out there who have very challenging epilepsies, who probably didn't have the benefit of our knowledge of genetic testing when they were younger, when they were just getting diagnosed. And there's now been a number of studies that have actually looked at what is the yield of genetic studies in adults. And importantly, if that gene was found, how often did that actually affect treatment? And you can see here that the yield in adults with epilepsy, that is drug resistant and intellectual disability, is about 1 in 4. So about 1 in 4 adults are found to have a genetic cause. And looking at how commonly does that actually affect what we do, so how often does it alter treatment, anywhere from 12% up to 50%. So I think we could all argue that this is also a very, very important test to consider in adults where the cause of the epilepsy is not yet known. So it's not too late to do genetic testing. So just to review the yield of genetic testing in a specific case, this was Jenna. And Jenna's 7 years old, and she was brought to the emergency department after suffering a seizure in a swimming pool. She had seizure onset at 4 months after her immunization, and that was a 45-minute right-sided seizure. Since then, she has had recurrent seizures that have not responded to medication. She has both focal as well as generalized tonic-clonic seizures. She has had multiple bouts of prolonged seizure activity, status epilepticus. She has had atypical absences. She has had myoclonic jerks. She has been through 10 medicines. She has tried the ketogenic diet. She has also tried vagus nerve stimulator, and those have failed to achieve seizure control. She has had 4 MRIs, all of which were normal. She has been through 15 EEGs, which showed multifocal and generalized discharge. She has been through 3 video EEG recordings to see if she might be a candidate for epilepsy surgery, and that was deemed not to be the case. She has had an extensive metabolic workup that was negative. So what's missing? And I think you would all say, gee, she needs a genetic workup. And she in fact did have a genetic workup and was found to have a pathogenic variant in her SCN1A gene that was consistent with Dravet syndrome that really explained very, very much her clinical picture. And I think, we would prefer not to make this diagnosis when she's 7. We would prefer to make this diagnosis in the first year of life, because I think we now have some pretty good therapies for this. So what did we do with her? We stopped her lamotrigine, which we think was making her seizures worse. She started fenfluramine that was added to clobazam, and she had a marked reduction in seizures. She has had no further status epilepticus over the next 2 years. So very significant benefit. And we know now that there are a number of genes that have either a definite or a possible impact on therapies. Here's just a smaller list, but we can see here that there are certain genes, for example, the SCN1A gene that I just told you about, that tells us we want to avoid certain medicines, particularly lamotrigine and phenytoin. Other genes, phenytoin is actually very helpful. So you can see here by understanding what is the cause and what is the specific genetic cause, that really helps clinicians know what is the best treatment to use for the epilepsy. And furthermore, we are now evolving to precision therapies in certain genetic epilepsies. And for Dravet syndrome, this is actually very exciting. There's an ongoing and some planned clinical trials that really look at specific genetic therapies which target the underlying abnormality that leads to the cause of epilepsy. And so these precision therapies potentially can not only help the seizures, but can also help some of those comorbidities, the learning problems, the gait difficulties, and things like that, that often go along with these genetic epilepsies. And I think we are just now really in the infancy of these precision genetic therapies. We're going to see a lot more of these coming out over the next few years. So moving on to metabolic causes, these are relatively rare causes of drug-resistant epilepsy in children. And collectively, they make up a very, very large number of disorders. And so what does this mean? So the metabolic causes result from either inadequate availability of a nutrient that your brain requires to function. So something like sugar, we all know your brain requires sugar to function and you can't get that. Or some type of a buildup of a toxic substance that then prevents the cell from functioning normally. And that's what we call a storage disorder. So those are kind of the 2 causes or the 2 big groups of metabolic disorders. So just to give an example here, this is an 8-year-old girl who I saw who had had drug-resistant epilepsy since 3 years of age. In addition to her epilepsy, she had a cognitive impairment and she had autism. She had had a normal MRI. She had undergone quite a number of metabolic tests and spinal fluid tests. We did an MR spectroscopy on her, which is a special type of MRI, and we saw that she had a low creatine. This is the peak here, and normally that should be up here. Hers was quite low. And so we followed that up with genetic testing, and she was found to have a creatine transporter deficiency. And why was that important? Well, she started supplemental creatine, and she had a marked improvement in her learning, and her seizures really, really markedly improved. She has the occasional seizure when she gets sick, but otherwise she is much, much improved. So again, we can see that knowing the underlying cause was really, really allowed us to choose the best treatment for her. Moving on to immune causes. This is a group of causes where the body produces an abnormal protein, and it acts on the brain to change excitability of the brain and leads to seizures. And typically children who have immune causes for their epilepsy will also have other non-seizure symptoms. So many of them will have behavior changes. They can have changes in their sleep. Many of them have associated movement disorders that are not seizures. And typically what we look for here is we look for this abnormal protein either in the blood or on the spinal fluid testing. And if we find this abnormal protein, that really carries a pretty high risk of drug-resistant epilepsy unless we pay attention to that protein and try and treat that specifically. So here's an example of a young fellow who was found to have an immune cause. So this is Julian, who's 11. He had seizures for the past year, and his seizures were focal seizures. They affected his right foot, and he had this continuous or near continuous right foot twitching. He was unable to run. He was walking with a limp. He had difficulty on stairs. What was most challenging for him is he was a really avid soccer player, and he could no longer play soccer. He also had bigger seizures, and those were seizures that started with twitching of his right foot, but then progressed into a generalized tonic-clonic seizure, and that had happened several times over the last couple of months. He had been on 4 anti-seizure medicines, none of which had worked. And he was now having increasing difficulties in school. He was getting quite depressed because he was unable to really do his normal activities. So hopefully this video works. And what you'll see here is he's got this constant little twitch in his foot. And that was there pretty much all the time. And it looks pretty subtle there, but this actually impaired his ability to walk well and impaired his ability to play soccer. And he was having increasing seizures that would start like this, that would then spread and become generalized tonic-clonic or grand mal seizures. So he had a normal MRI. We recorded a bigger seizure, and his seizures started in the left central part of the brain. He underwent spinal fluid testing, and we found evidence of inflammation in the spinal fluid, and that's often a clue that there could be an underlying immune cause. So we see elevated white blood cells and elevated protein and evidence of inflammation. And we also found an abnormal antibody, an abnormal protein that was really attacking the brain and causing his seizures. And so he initially was treated with steroid medicine, and we do that to try and suppress the immune system. And that improved, but then he ultimately relapsed, unfortunately. So we started another immune suppressive medicine. And he has had very significant benefit over the last 3 years. He's had no further bigger seizures. He has some occasional right foot twitching, but he's really gained a lot of his normal function back. He's able to run. He's now able to play soccer, and that's really what he's lived for. So he's very excited about that. And he's doing much better at school. So I think importantly for immune epilepsies, we really want to recognize this early. We want to treat it early with immunotherapy so that there's not ongoing injury to the brain that may not be recoverable. So moving on to infectious causes. So this is meaning some type of a brain infection that leads to epilepsy. Here's an example of a child with a brain infection called neurocysticercosis. We see these occasionally in the US. This is a little more commonly seen in the developing world. And again, these have very specific treatments, really targeting the underlying infection. So asking the question, how often can we actually find a cause for epilepsy? And in kids with epilepsy, we find a cause somewhere between 50 and 60% of the time. And that's with, doing the MRI, thinking about genetic causes, thinking about metabolic and immune causes. About 50 to 60% of the time, we find a cause for the seizures. We know that a cause is more likely to be found the younger the child is at the time they develop their epilepsy. So particularly in the first year of life, it's pretty common to find a cause. Sometimes we don't find them in later in childhood or adolescence. We are more likely to find a cause if these seizures are drug resistant, so they're not responding to medication. And if there's associated findings, so if there's associated intellectual disability or cerebral palsy or things like that, we're more likely to find a cause. So let's move on to the bottom here, and this is the green box, the Epilepsy Syndrome box. And this is epilepsy, or this is Disney syndrome. So what do we understand by an epilepsy syndrome? So an epilepsy syndrome is a distinct entity that we can actually identify as clinicians and as families who have loved ones that are affected. And there is a cluster of features that kind of comes together in this entity. And typically that involves children developing seizures at a particular age. So if we look at syndromes, they'll either start predominantly in the first year of life, or they'll start sort of in later childhood, or they may all start in adolescence. So it's the age at onset that the person develops their seizures. It's the seizure types. So some syndromes are more focal seizures. Some syndromes may include absences or tonic seizures. It's the features that we see on the EEG. And then the associated factors are the comorbidities, things like developmental delay. And so if we put all of these together, all of these factors together, they form a little cluster. And when we look at that cluster, we can say, aha, this is very suggestive of Lennox-Gastaut syndrome, or this is very suggestive of juvenile myoclonic epilepsy, or this is very suggestive of West syndrome. Some of our epilepsy syndromes are also highly correlated with a single cause, and a good example there would be Dravet syndrome, where most persons have a change in the SCN1A gene. But other syndromes have much more diverse causes, and good examples of that would be children who have infantile spasms or children who have Lennox-Gastaut syndrome, where we know sometimes it's a structural cause, sometimes it's a metabolic cause, sometimes it's a genetic cause, so there's quite a range of different causes. We also know that syndromes can have very clear implications for treatment and prognosis. And overall, if we look at children, somewhere about a quarter to a third of children will have an identified syndrome, but finding the syndrome in adults with adult onset epilepsy is less common. And so here's the number of epilepsy syndromes that we have. And if we think about these, as I said, we typically think about when is the age of onset, and that's sort of the rings of the tree here. So you can see some syndromes present very early in life, some syndromes present later. Some syndromes present predominantly with focal seizures, some syndromes more with generalized seizures, and some with both. And then some syndromes are more what we call benign, and these are often syndromes that are self-limited, that will be outgrown and not associated with any developmental problems. And then some of our syndromes are more severe. They're very, very rarely outgrown, and they are commonly associated with other comorbidities. And so that's kind of how we think about syndromes. So I just wanted to give you a couple of examples here. So this is Lisbeth, who I met at 5 months of age, and she was having daily clusters of flexor or extensor spasms at 4 months of age. Her family also noted that she was less visually interactive since her seizure onset. She wasn't gaining any new skills. She had been started on levetiracetam, and that had not benefited her seizures. And this was her EEG, and this EEG showed a particular picture that we call hypsarrhythmia, which is highly associated with West syndrome or infantile spasms. It's a very abnormal picture with lots of discharges. And so we were able to diagnose her as having West syndrome or infantile spasm syndrome. And this is a really important syndrome because it's the most common severe epilepsy that occurs in infancy. Children may be normal or sometimes are delayed prior to the onset, but we know that with the onset of spasms, typically their development progresses, or their development either regresses or plateaus unless they are actually adequately treated. And so the diagnosis of infantile spasms or West syndrome is important to allow us to choose the best treatment. We know here that hormonal therapy or vigabatrin or a combination should be used first line. And it's also really important to appropriately counsel the family. So we know that with infantile spasms, even with treatment, many children are left with drug-resistant epilepsy and developmental delays. And so that's a conversation that I think the family needs to be aware of when we are diagnosing this, that there could be problems down the road. So she started on high-dose oral steroids. Her spasms stopped within a week and her EEG returned to normal. She was visually more attentive. She was gaining new skills. But unfortunately, she then had recurrence of seizures and has now evolved to Lennox-Gastaut syndrome. So moving on to Arthur, he's a 3-year-old boy and he was previously well. At 24 months of age, he had onset of his first seizure, and that was a 10-minute seizure, generalized tonic-clonic seizure with fever. Not too much was thought of this because his father also had febrile seizures. At 28 months, however, he started having increasing seizures and was starting to have a lot of seizures. And with that developmental plateauing, he was quite clumsy. He was quite off balance when he was walking. And he had now been tried on 3 different medicines and his seizures were not responding to that. And the family had been told that he had Lennox-Gastaut syndrome. And according to the family, nothing more can be done for him. He will be severely intellectually disabled. So they were obviously very, very devastated at that news and sought a second opinion. So he came in, we did a video EEG. He had quite a number of seizures just over the 24 hours. He had jerks, myoclonic jerks. He had a specific seizure type called a myoclonic atonic seizure where he would jerk and then he would drop. And importantly, he did not have any tonic seizures. He had quite a bit of testing and no cause could be found. But because of these myoclonic atonic seizures, we felt he had myoclonic atonic epilepsy or induced syndrome, not Lennox-Gastaut syndrome. And this is a very important call to make because we know that in his case, the correct syndrome definition really allowed more clearly us to delineate the prognosis for the family. So we know that children with myoclonic atonic epilepsy or induced syndrome can have more challenging seizures initially, but their epilepsy often remits with time and the cognitive outcome is much better, whereas seizures in Lennox-Gastaut typically do not remit and remain drug resistant. And it also allowed us to choose the optimal therapy for him. And so we know oxcarbazepine shouldn't be used because it worsens generalized seizures, so we stopped that. We gave him a trial of valproate and he did not respond to that. As you can see from the picture here, he started the ketogenic diet, he became seizure-free. And at last follow-up, he was still on a milder version of the ketogenic diet, the low glycemic index diet, and had made remarkable developmental catch-up. He was getting some minor help in reading, but otherwise was grade appropriate. So we know now that there are a number of syndromes that have specific therapies, and those are listed here. And so it's really important to allow us to choose the best treatment early on. This is the last case. This is Christopher, who was previously well, came into the ER with a 5-minute generalized tonic-clonic seizure that occurred just before awakening. He had also had 3 other episodes that occurred shortly after he fell asleep, where he felt his tongue and the side of his face went numb and he was drooling. The other was a normal kid. And here was his EEG, and we saw very abundant right and occasional left central temporal discharges. And so he was diagnosed with a syndrome called childhood epilepsy with central temporal spikes. And allowing this really ensured that we avoided unnecessary testing. So actually we didn't do an MRI in him. We were able to clearly say that he will outgrow this. This is always outgrown. And it also provides guidance on treatment. So seizure medicines may not be needed for him. So the question then is, does best treatment actually lessen comorbidity? So yes, we can improve maybe seizure control, but does that make a difference long-term? And I think here the answer is yes. So just a few examples. This is for patients with structural causes who have infantile spasms. And this is looking at their development after surgery. And this is going from the lowest to the best development. And here's the duration before they had their surgery. And so you can see here, the longer the child goes before they actually get to surgery and have their seizures controlled, post-operatively, the poorer they do developmentally. And so that really tells us the importance of seeing these kids early. For metabolic causes, we know that early interventions can actually prevent further developmental declines, which may not be reversible if the treatment is started later. And a good example of that are children with glucose transporter deficiency, where we know the ketogenic diet is really, really effective, but it needs to be used early to save development. And even in Dravet syndrome, we know that using the wrong medicine that worsen seizures can actually have a long-term impact. So this was a study that was done in the Netherlands, and this is looking at children who received contraindicated medication for longer periods of time. And the red line are those who receive the longer duration contraindicated medication. The blue line are those who received the contraindicated medication for only a short time or did not. And then this is looking at the long-term development. And again, you can see that the longer you use the wrong medicines is associated with poorer developmental outcome long-term. So really identifying to us that we need to be using the right medicine, and we need to understand the cause and the syndrome. So to conclude, the cause of the epilepsy and the syndrome are highly predictive on how that epilepsy is going to behave. So are seizures going to be drug responsive or drug resistant? How likely is it that epilepsy is going to be outgrown? And how likely is it that the child will develop comorbidities, and what types are those? The cause and the syndrome often inform the best therapeutic options. And then we know that the best treatment early on may improve long-term outcome, not only related to seizures, but also with regards to development. And then increasingly, we're seeing these precision therapies, which really are going to target the underlying cause. And we really want to be sure that we have children that can rapidly start these therapies once they become available. So thank you very much for that.
Outstanding. Thank you very much, Dr. Royal, for that great introductory talk today. There are a few questions that have come in the chat. And just as a reminder to everyone throughout today, if you have questions for the talks, just put them into the chat, and then I'll try to bring them up at the end of each talk with the speaker. And then if you have questions that come up later on, we'll also have a brief 20-minute period at the end where some of us will be able to rejoin and answer some questions, though not all of us will be able to attend during that time point. So 2 questions for you. The first is, can a brain malformation, such as a cortical malformation or dysplasia, be identified before birth?
So it can occasionally be identified before birth. Brain malformations are notoriously challenging to identify, often in early life, and particularly between about maybe 4 to 6 months of age and up until two years of age, just because of the way the brain develops. Before birth, typically the testing that is done is just an ultrasound, and if the brain malformation is particularly severe and extensive, you can sometimes see it on ultrasound. The more subtle ones you might be able to see on a fetal MRI, but those are rarely done. And even the fetal MRI can miss more subtle changes. So we can't always identify, we can identify, I think, bigger malformations, but we can't always identify the more subtle ones.
Great, thanks. Okay, so the second question is, how permanent is the diagnosis of a syndrome? Can a child develop a new type of seizure, which may be indicative of a different diagnosis?
Yeah, that's a very good point. So we know that sometimes syndromes do evolve from one syndrome into another. So some syndromes stay the same from the get-go. For example, Dravet syndrome does not change and become Lennox-Gastaut, or does not change and become another syndrome. But we know that other syndromes can actually change and evolve. So a good example of that is a child who has infantile spasms. And we know that you don't stay with infantile spasms through your whole life. Many of those children will then evolve as they get to maybe 3 or 4 years of age and develop other seizure types like tonic seizures or drop seizures, and a generalized slow spike wave, and can then evolve into Lennox-Gastaut syndrome. We also know that some of the better behaved syndromes, like for example, childhood absence epilepsy, can sometimes evolve to what we call juvenile myoclonic epilepsy in adolescence. So sometimes we do see some of these syndromes evolving into others.
Great. Well, thank you. Thanks again for joining us today. Appreciate
Thank you.
Time. Yeah, that was great. So we're going to move on now to the next talk. So our next speaker is Dr. Tracy Dixon Salazaar. And if you don't know her, she is a neuroscientist, a geneticist, and an innovative patient advocate. She had a desire to get a PhD that was inspired by her daughter, who developed a rare epilepsy syndrome at the age of 2 years of age. She did her PhD and postdoctoral work at the University of California, San Diego, where she studied the mechanisms of brain development and synaptic plasticity, identified genetic causes of neurological disorders in children, and investigated precision therapies in cell-based and animal models of pediatric brain disease. And today, she's going to take us through Lennox-Gastaut syndrome as an example of a syndromic diagnosis and the importance of having that diagnosis. So Dr. Dixon Salazaar, thank you for joining us.
Great, thank you. Can you hear me all right and see my slides?
Yes, we can.
Awesome, thank you. So it's so great to be here. I wish we were all at Disneyland as well instead of in our homes and experiencing pandemic, but I am glad that we can all come together this way on Zoom, so it's really nice. So I'm going to talk and be a little bit redundant with what Dr. Worrell just talked about, but I'm going to talk specifically about Lennox-Gastaut syndrome and then my family's journey with Lennox-Gastaut syndrome. So currently I work at the LGS Foundation as the Director of Research and Strategy, and I'll be telling you a little bit more about our story as I move forward. So what is LGS? You've already heard this, and you've heard this from Dr. Worrell, but LGS is just one of many syndromes that exist for the early life epilepsy syndromes. Now, if you have time down here at the bottom from birth to 1 month to a year to 10 years to adult, and you can see different syndromes will pop up at different times along the way. And so Lennox-Gastaut is just one of those syndromes. And I think it's important to have this historical context because when I first joined, the Lennox-Gastaut syndrome world and the epilepsy world, it was all really confusing to me. Like, where did all of these names come from? And actually, these names evolve over time as our science and our understanding evolves. So Lennox-Gastaut syndrome, LGS, was actually, the EEG features of it were first described back in 1939. And then it was officially named Lennox-Gastaut syndrome in 1969. So we've got, more than 50 years of data and information about this syndrome. And this was back when science was really all about observing what was going on in patients, observing with what technology we had, EEGs back then, and then describing in detail what they were seeing in patients. We didn't have genetic testing back then. We didn't have really advanced imaging back then, like the things that you saw in Dr. Worrell's talk. And so the syndrome has really evolved. And not only that, the name of LGS has evolved over time. So each of these, I have to update the slide here and get the newest papers on here, but back in 1950, the original features of LGS were, childhood onset was not required, an intellectual disability, more than one seizure type, tonic seizures and sleep, diffuse, slow, spike and wave, and then fast rhythms. And each of the different papers that were published, if you see a check mark here, it was required for the diagnosis. So it's right now we're operating on a system where very young people with LGS are getting diagnosed one way, and there are older people, who are in their 60s, and we do have people in our LGS Foundation community that are in their 60s, who are diagnosed in a slightly different way because the definition has changed. But as you heard from Dr. Worrell, the main definition, the main criteria that we use now is through the ILAE criteria, which is the International League Against Epilepsy. And they've done a lot of work to really parse out the different syndromes. But you really need to have tonic seizures during sleep or associated with sleep state, slow spike and wave on the EEG, paroxysmal fast activity on the EEG, an abnormal EEG background. And multiple seizure types is also present in everyone that I have ever seen published on with LGS, has multiple seizure types. And cognitive impairment is not required for the diagnosis of LGS, but it is present in most within 5 years of diagnosis. My daughter was perfectly cognitively normal at the time of her LGS diagnosis, but then started to delay after that. So it's really important to understand when it's important, what are the different features and when you were diagnosed and what it means now, because all of this has implications on the help that you're going to get as a family living with LGS. Dr. Worrell talked a lot about etiologies of LGS, and these are just listed here again for you. Brain malformations, vascular abnormalities and infection. A number of different genes can lead to LGS, tumors, traumatic brain injury, metabolic. And I'm going to show you this slide represented slightly differently in a bit, but about 10% to 25% still don't have an identified cause. And that number has really changed since I came into the space nearly 30 years ago, where it was really 70% were thought to have, a structural abnormality, and we didn't know the cause in most of the rest of the patients. So As Dr. Worrell talked about, LGS is an epileptic encephalopathy. So it starts here with seizures. And then those seizures lead to a really abnormal EEG pattern. Slow spike and wave of LGS is a sign that something has gone horribly wrong in brain development. And once LGS is present, once the slow spike and wave is present, it makes it really difficult for the child to learn and develop and grow. And that then, in addition to whatever was causing their seizures, that epileptiform activity that's abnormal also starts to impact their development. And the way that, I mean, all of these grids that I just showed you and these representations for LGS, whether it's a table or a triad picture bubble or a list or something like this, where there's an arrow leading to an arrow leading to an arrow, are one way to look at it. But the way that we look at it at the LGS Foundation is really across the family journey. The LGS journey, the evolution of LGS over time. And for us, it looks something like this. So over here in the early ages, you have your etiology, your cause of your seizures that lead to LGS. And you can see here the breakdown. You've got, congenital, you've got injury, genetic, and so on. And these etiologies will lead to the first seizure. And this can happen the seizure can happen at any age. We may not know the etiology, but the seizures are really coming from something. There's some reason the seizure begins. And then after the second seizure or the seizure progresses, you then are diagnosed with epilepsy. And if that becomes an intractable epilepsy, then you develop a treatment-resistant epilepsy. Along this, there can also be a syndrome, like Dr. Worrell said, 30 to 50% of LGS patients had previous infantile spasms before they were diagnosed with LGS. So you can have another syndrome in addition to, all of these other things. And along this trajectory, other seizure types will emerge and developmental delay will emerge at some point. It doesn't really matter where you kind of came from and what your trajectory is, but once you have LGS, which is over here, which is more than one seizure type, the slow spike and wave on EEG, the fast activity on EEG, the cognitive impairment once that has developed, and the early age of onset. Once you have that, the outcomes tend to be pretty similar, and they're not really in the favor of the child who has LGS. So most of them will continue to have seizures into adulthood. The majority will be moderate to severely intellectually disabled. There is a high mortality rate. There is a lot of incidence of status and so on and so on. So what LGS really is this evolution from, a brain that is developing, and that brain then becomes derailed because, as a neuroscientist, we learn this term, cells that fire together, wire together. And when you have a seizure, the cells are all firing, but the brain is still developing. And the brain is supposed to be developing without all of that abnormal firing. And so when you get that constant barrage of seizure, of that constant barrage of firing, you get abnormal wiring. And that is really what LGS is. It's a disorder of the network, this larger network as the brain develops. So that's one way. Those are multiple ways to think about LGS. It's really complicated. So I always like to give multiple ways to think about it for whatever might resonate with you. And this is the way that we think about it at the foundation, because we work really hard, and I'm going to come back to this, to serve families who are living with LGS. And this has been an ongoing effort, really identifying things that can stop the seizures and supports. But there's this whole new field that's emerged in the last 10 years of really identifying the etiology, focusing on the etiology, and trying to treat that. And there's a whole opportunity for us now to think about treating the evolution. Is there a way to target early, not just the etiology, but also the EEG abnormality? We don't know much about the mechanisms of slow spike and wave, but technology is at a place where we can maybe begin to parse that out and think about treating that, which is clearly a very bad sign whenever it shows up on an EEG. So we want to talk a minute about our LGS journey, because when I came into this space, like I said, nearly 30 years ago, I have a 28-year-old with Lennox-Gastaut syndrome. I knew nothing. I was a young stay-at-home mom. I had her when I was 21 years old. She started having seizures when I was 23. And I had not gone to college or anything. And it was just really confusing for us. And, I just kind of want to tell you a little bit about our journey and how I sort of became educated. And I'm trying to, circle back and help the next generation to understand what I've learned about LGS so that we can then, go further, faster, all of us together. So this was our introduction into the world of epilepsy. This is my daughter, Savannah. She was 2.5. And we awoke in the middle of the night to the sound of her hacking and gagging. This is the harsh introduction into epilepsy that all of us as caregivers and loved ones face. We felt utterly helpless. We had absolutely no idea that she was having a seizure. We thought she was choking because my husband and I had no idea that she was having a seizure. And I will remember the paramedic came and he said, you know, what you've described sounds just like a seizure. You know, her airway is clear, but that sounds like a seizure. And our reaction to that was, well, what is a seizure? The first seizures that she had 4 of them. They were all generalized tonic-clonic. I didn't know that. Back then, they were also still called grand mal seizures. I didn't know that they were seizures. And, you know, we had the big video camera on our shoulder, you know, it's like this big, trying to videotape your kids seizing when all you want to do is be there and hold them. But so she had 4 seizures, and then she went 6 months without having any. And then 6 months later, at the age of 3, they came back, and they came back with a vengeance. This is a myoclonic seizure. These would throw her to the ground. And this is what we saw as an atypical absent seizure. She was ultimately diagnosed with 6 seizure types. She was having, by the age of 3, anywhere, you know, from 5 to hundreds of seizures a day. One day could be 5, the next could be hundreds. And she wasn't diagnosed with Lennox-Gastaut syndrome until the age of 5. And mostly that was based on technology, because back then it wasn't customary to go in for video EEG monitoring long term. You could only get that at specialized hospitals. So we've come a long way in diagnosing and finding these kids faster. But even then, when we found out that she had Lennox-Gastaut syndrome, we were like, well, what does that mean? So we just felt really powerless, you know, from going from this really healthy child who developed normally and typically till the age of 2.5. She was not precocious. She was not delayed, to seizures, you know, to the point where she was, you know, growing and developing, and the developmental regression set in. She just stopped developing, and in some areas she completely lost her skills. So our odyssey from the time she was 3 to the time that she was 18 was really something that looked like this. She had more than 40,000 seizures. All I could really do was count them. So I just counted them, because what else was I supposed to do? I couldn't stop them. Took us 3 years to get the LGS diagnosis. Up until then, she had been diagnosed initially with spells or episodes, because they didn't want to label it epilepsy, and then epilepsy, and then intractable epilepsy, and then finally Lennox-Gastaut syndrome. We had seen 7 neurologists up until that point that we got the diagnosis. We had tried and failed 26 different therapies, including diets and devices and medications and alternative therapies. And you can see there, she had been hospitalized many, many times and was using emergency rescue meds. The only med back then was Diastat, very, very frequently. And so here's a graph of what her seizures look like across that journey. You can see that just each year, the number of seizures she had. And there was really no pattern. If you broke this down based on the daily seizure numbers, you'd see the same thing. You see this roller coaster of number of seizures. And I think the thing that was really frustrating and frightening to us were the number of times that she would go into non-convulsive status. If you remember the video that I just showed you, the very last seizure where she's sitting on the couch and she's sort of staring and she's twitching her fingers and her eyes are fluttering, that could go on for hours, days. The longest it ever went on was 4 days, because the doctors were not convinced that that was a seizure. And so we really couldn't get ahead of it, and then it went on for a really long time. And this is a graph where we were using Diastat over here on the left, and the number, and each month is over here. And so you could see it was increasing over time. Oops, sorry about that. And, you know, by the time she was 18, she was getting Diastat, emergency rectal medication, about 2 to 4 times a week, just to stop the status, in addition to her other 7 anti-seizure meds and her device. So this is, you know, this journey that we went on is really what propelled me to look more into epilepsy. And I was just so shocked when she was 5 years old and got the LGS diagnosis to find out that epilepsy was a spectrum disorder. And we didn't really talk about it. We always, you know, back then we just talked about, oh, you can be controlled, you can live a normal life. And we weren't talking about the severe end of the spectrum. I was really shocked to find out that, you know, 3 million Americans had epilepsy, and that most of the cases started in childhood, because back then we really didn't talk, again, we didn't talk about, we didn't really make therapies for the younger ages. We talked more about adult epilepsy. And we didn't talk about the 30 to 40% that were intractable, that didn't respond to medicine. You know, it really, that was the time that we came into. And so we've come so far now because we actually talk about these things now as a spectrum and how many people have it. But we felt so alone, like we were the only people on the planet with epilepsy and with LGS. I was shocked to find out that, you know, in epilepsy, that 70% of the causes were unknown back then. And even back then, they wouldn't even say cause unknown. They would say it's idiopathic, which, like, I don't know about you, but I had no idea what that meant as a mother. So why are the causes unknown? And there was this huge economic burden. In addition to that, doctors would tell us, you know, there's all these medicines that are on the market. And so thankfully, like, I actually have this quote from one of my favorite doctors of all time, but thankfully we don't need to know what causes epilepsy in order to treat it, because look at all these meds we have. And that was despite the fact that over years, every time you would do a study, these were studies that were published across the years on intractability rates in epilepsy. They didn't really change at 36%, 33 to 38%, 38% here in 2005, and so on. And so it just seems so contradictory to me. It's like, you're saying we don't need to know what causes it to treat it. None of the treatments are working. My daughter, the data in the literature isn't really suggesting that the intractable rate is going down or that the prevalence rate is going up. I'm just really confused. And then the data that I stumbled across in 2000, which everybody pretty much understands now, is that the chances of you becoming seizure free after you fail a certain number of medicines gets lower and lower and lower and lower. And so, you know, about half will become seizure free on the first medicine. But at the end of the day, you know, the odds of you responding to the third medicine down here is about 1%. And they repeated the study 12 years later, and it hadn't really changed all that much. It had changed, and I am super happy for the 4% that did become seizure free.
Bigger.
But
so you don't need anything, right? Because I gotta call Cecilia.
Okay, he's not talking to me, so we'll just keep going. So this is what really drove me, and then this is the figure that really drove me to my next step, was that, you know, if you looked across 1975 to 2014 in this paper published by Thomas and Berkovic, we had not really made a huge dent in the number of causes, the root causes of epilepsy. And so it was this what really drove me, this and the fact that my daughter and I and so many others that I had started to meet were stuck in this continuous loop of, you're not a candidate for surgery, but maybe you can't do resective surgery, but you can do palliative. Maybe there's a corpus callosotomy, but if that doesn't work, we'll go back to another medicine. And if that med doesn't work, we'll go back and we'll just give you another medicine and another treatment and another treatment and another treatment. And maybe there's a study. And so at the end of the 16-year period, we'd really tried and failed 26 different things. And this is what led me to go to college. And this and a total inability to help my child led me to go to college. And ultimately, after many, many years of remediating, because I was a terrible high school student, I got my PhD in neuroscience. And people always ask me how I did that. And I don't really know. I didn't see my husband for 12 years. But it was, I just wanted to be a part of the group of people that were helping identify causes of epilepsy. And it turns out that I did. I joined, and I'm going to show this slide again, but Dr. Royal showed a slide of the genomic revolution that happened in the epileptic encephalopathies. And I was in college, starting my postdoc at the time that the genomic revolution hit. And we had really great success. One of the biggest first successes that we had, in addition to finding genes, was a precision medicine therapy for our daughter, Savannah. And I'll just explain that really quickly for you. So it turns out that if you do DNA sequencing, if you did DNA sequencing in Savannah, which we did in the lab, she has quite a few mutations. And these are all shown here as these little red dots in calcium channel genes. So initially we sequenced her whole exome and we did not find any of the known epilepsy genes that were there. But when we just kept digging and looking, we found that she had this really high burden of calcium channel gene mutations. And I think that many of you on the call already know that calcium channel genes are very important in epilepsy and nerve signaling in general. And so this could really explain why she might be having seizures. So we really dug into her variants in the lab, and these are listed here. Many of her mutations, especially the most impactful ones, existed in L-type calcium channel genes. And so this really led us to believe that this might be the driver for her epilepsy. And we began to mine the literature for models of how these mutations could be acting. And we began looking at the symptoms in Savannah. And after a grueling analysis and a risk-benefit comparison, we really believed that Savannah had too much calcium going into her cells, so a calcium overactivation disorder. And there's actually a drug on the market. It's called verapamil. It is not used for epilepsy, really. It's not approved for epilepsy, that is. It's used for high blood pressure and arrhythmias. We thought we might try that in her. And I just want to be really clear before I show you the data that this is a very important risk-benefit of analysis to do. And if the science isn't supporting it, you would never want to try something like this with your kid. But all of the evidence was pointing to the fact that she had too much calcium going in instead of too little calcium. But we tried her on this drug that would reduce the amount of calcium going in. If we had got that wrong, we really could have done harm to her. But at that point, she was 18 years old. She was the mental age of a 3-year-old. She was on 7 medications plus a device, plus getting rescue meds 2 to 4 times a week, plus sleeping 18 hours a day and barely able to really get her words out. So for us, it was worth the risk. So we tried this drug verapamil, and immediately within 2 weeks, we saw a reduction in her seizure numbers. And even more shocking for us, so this is just a graph of some of that time, we saw her use of rescue medicines to stop her non-convulsive status epilepticus completely stopped. And this year we will be celebrating her 10th year on this drug, and Savannah continues to do really, really well. It's not perfect. She is not seizure free. She has about 2 to 3 seizures a week, but that is down from the 75 to 100 she was having every week. And she does not go into status anymore. So here's a picture. This was her senior picture when she was 18, and she is doing really well on this drug. Here's a video of her with her dog just being silly and sassy, talking and awake, which is a big deal for us compared to the kid that we had before. So,
She doesn't spend her day seizing, unconscious. High five.
So Savannah's doing really well, and what her story I think beautifully illustrated back then at the turn of the genomic revolution was this possibility of precision medicine, something that was already happening outside of the epilepsy space but hadn't really taken root and taken hold. And so it really was, I think her story inspired a lot of people in the field to keep pushing, and the field has come so far in that regard. The genomic revolution, which Dr. Worrell really showed, Savannah was right about here in identifying the gene. I started my postdoc in 2010. We identified her gene, and we've identified just so many genes since then. And even this needs to be updated. I should get Dr. Worrell's slide. And all of those genes overlay now all across these syndromes. So this syndrome diagram that I showed you is still there. You have a syndrome and you have a gene, but there's this figure that is in a paper that came out by Amy McTague and Ingrid Scheffer that really shows it nicely. We're here. So here you have Lennox-Gastaut syndrome, just like you had on the previous slide, which is the syndrome, and the genes that are associated with it, infantile spasms, genes that are associated with it. And we're across time and the ages that the syndromes come on. So we're really beginning to identify the genes that are associated with each syndrome so we can start to think about this concept of precision diagnosis and precision treatment anymore. And I mean, I'll just jump to the punchline. This is a reality, as you heard from Dr. Worrell's talk, that there are precision treatments that are being targeted very specifically. If you have this, the ketogenic diet might work for you. If you have Dravet, avoid these drugs and watch for these issues. If you have Dravet syndrome, you can also enroll in these trials that are coming out. If you have tuberous sclerosis, here's another option. And this just isn't just true for the genetic epilepsies, it's also true for the acquired epilepsies as well, as we start to think about birth injury in newborns and how we might treat them with whole body cooling, and how we might think about the inflammatory process of an injury as it goes to to a seizure, which could then lead to LGS. So it's a really exciting time in science to be thinking about this idea that instead, back in the day, we used to group everyone with epilepsy and there you were. But if we can break you out and say, the guys here in the red, these ones have this gene mutation. And so this is really the treatment that they should go on. And maybe it's not a drug, maybe it's a diet, maybe it's a device, maybe it's something else. And these ones in green have this other thing and they should really go on this. And we're beginning to parse that out, and it does exist. But in order to do that, we also need to think about the journey. So I want to go back to the journey map and just end here with my next 3 slides. We really have to understand where we're at in the journey. Treating etiology first, if treating a gene or whole body cooling in an infant who had a birth injury, really could help to prevent the progression of the disease. In addition, I do think we're missing a huge opportunity in the epilepsy space to be targeting something like the slow spike and wave on the EEG. So I hope that we do that in the future. But it's not, all is not lost. If you have an adult or who's had seizures for years because of their rare epilepsy, especially with LGS, we know Savannah was 18 years old when she went on her drug that really helped her, and it didn't fix everything. Savannah still has seizures. She doesn't go into status anymore, but she is growing again and learning again, and it made a big impact. And we know that adults can benefit from precision medicine as well. It doesn't fix everything. So, really, I just want to reiterate it again. You've got your etiology. You want to treat that, and you want to try to stop the seizures. The seizures can then lead to really abnormal electrical activity, and that would be an LGS, the slow spike and wave. And then that activity can really impact development in addition to the seizures. And one of my favorite analogies, even though it's really sort of morbid, and I hope you'll forgive me for it, it actually comes from Amberg, who describes LGS as something more of a train wreck, which has definitely been the experience in my life. So I don't mean that humorously, but that is what our life has felt like. But the idea is that you have the initial thing that caused the accident, but then because of that accident, you get this pile up, and most of the damage is done downstream. And I think that we can really treat the etiology, and we can think about the downstream and how we can manage here across all of these. And hopefully, as we move forward in time with the science, there will be less and less LGS, which is the back of the train here, unfortunately, for many of us. So I just want to end here by saying that Savannah has 3 DEE diagnoses. She's got epilepsy plus intellectual disability. She also has LGS. She also has a calcium channel disorder. And I know that there's a lot of people in the field that are like, just pick, you got to pick one. And actually you don't. You can get, and the reason you don't have to pick is because our lives are hard and we need help raising these kids and stopping the seizures. And so you need to be in whatever community. And we're going to be hearing about communities from Mary Ann, from Dravet Syndrome Foundation, and we're going to be hearing about communities from CAR, ATS. Whatever community is going to get you the support that you need. My personal take is that we should really divide on the science, but partner on everything else, because we're all living the same life. This is my friend Jen, her son has Theo, and this is a care plan map that she put together a few years ago based on another famous care plan map that's online. And she's got, Theo, she's Theo's mom, and Theo's 16, and she has all these areas of her life that she has to deal and protect Theo because he has LGS. At home, his personal safety, he's got to deal with his education, his recreation, his health, and financial. And then in addition to that, she's got all of these general needs in each of those areas. In addition to that, she's got all of these different organizations that she has to work with in order to meet those needs. And it's a monster to try to manage all of this. And to get, Jen has to be the quarterback for everything. And those of us that are living with the rare epilepsy know this. We feel this in our core because this is what we're still doing today, although it is getting easier. And so wherever you go, the load is heavy, but wherever you go, whatever organization is out there, find the ones that can support you, understand the diagnoses that your kids have, understand sort of what your options are, whether it's a precision therapy or it's better quality of life and healthcare services, or something else that is really important to you. And these organizations can sort of help you to move along. So LGS is a syndrome, but it's also a group of other syndromes, a bunch of genes and a bunch of etiologies. And we partner on everything else and the living with the life, but we divide on the science and fund science, you know, to move our fields forward. And with that, I just want to end saying, I hope next year we're all at Disneyland for reals. We had a great time and this pandemic will end. I can't wait. And thank you for being here. Thank you.
Well, thank you very much. That was outstanding as always. Never, and we never get tired of hearing the story. It's fascinating every time. Remember, if you do have questions, please just place them into the chat box and I'll be happy to share your question. Since we have a little bit of time, we're a little ahead of schedule. My question to you is, you'll encounter people who will say that as a whole, Lennox-Gastaut syndrome is not a very valuable diagnosis because it doesn't tell you what's going on. And so my question will be, what is your general response to those people?
Yeah, I mean, I think that, very kindly, I would say that it does tell you what's going on. And it does actually so much more than that. First of all, when you have LGS, it really doesn't matter what your etiology is. The outcomes and the life that is lived, the journey, tends to be very similar across all the LGS etiologies, right? And not just that, for all of, let's expand it beyond LGS, for all of the rare diseases. I partner very heavily with Kari from TS Alliance, from Marianne with Dravet, and from so many other organizations, because our families are on the same journey. We see the same doctors. We have the same issues with IEPs at school. We're dealing with the same drugs for seizures, right, and for behaviors. In addition to that, by getting the LGS diagnosis, you also are brought into a community of support. You are going to need help. Whenever I hear a lot of doctors that say to me, we just need to retire the LGS diagnosis and not use it anymore. And I actually totally disagree with that. And the main reason is because I think it will actually do harm. Just because science redefines something, right? LGS doesn't go away. There's still going to be people who have slow spike and wave, GPFA on EEG, multiple seizure types, cognitive decline. There's still going to be people who have LGS, but if we redefine it away by its etiology, instead of saying it's LGS secondary to calcium channel disorder, right? If we just call it calcium channel disorder, the system downstream is not going to change tomorrow. So if you get rid of LGS, which has been around since 1969, and you now tell me I have to call my kid her calcium overactivation disorder, I am never going to get services for calcium channel overactivation disorder. And I don't have a community without calcium overactivation disorder. And I don't understand prognosis with calcium overactivation disorder, but I understand it with LGS. I understand all those things. And in addition to that, I do think we have a real opportunity here, Scott, to study slow spike and wave and the mechanisms based on the science, and maybe begin thinking about treating that, the specific feature of LGS scientifically. The science has to catch up, obviously, and then moving it forward. But I really strongly think that we don't want to throw the baby out with the bathwater. We want to keep the baby, and LGS secondary to whatever the gene is. So, and if we do just redefine it, and then I'm going to tell everybody that I made LGS go away and I'm going to take all the credit for that. I can't cure LGS. We just redefined it, but I cured it. I'm kidding. Don't do that.
Excellent. Another thing is that, unfortunately for a lot of people, a syndromic diagnosis is not obvious. And unfortunately, neither is an etiology, especially not early on. What advice do you have for those families?
Yeah, and we see this a lot in the LGS community. We have we don't have cures over here, but we have an excellent community of support. And we have so many people in our community who are LGS-like, right? Maybe they're not LGS, but they've got some features of it. And my advice to you is, never give up looking for the etiology, because I do really think that targeted therapies as they come out can help at any age. There's anecdotal data across a number of diseases And in other diseases like cancer, not even anecdotal data, actual real scientific data, that even treating with a precision therapy at an older age can make an impact, because the calcium channel overactivation disorder was present in early life, but it was still present when Savannah was 18, right? And so still treating it. But also find your community of support that can help you, because there's a lot of communities out there, but you're going to need help. You know, saw that care plan diagram. At a certain point, there's always this journey that I see families go on, and we did the same thing. The first was, oh my gosh, what is it? What is it? What is it? And then once we knew what it was not spells or episodes, it was epilepsy. They were seizures. We were like, what caused it? And we probably went about 2 years of what caused it? We have to stop it. We have to stop it. And then about 2 years in, we shifted to, oh my gosh, how are we gonna live with this? And I think you have to shift, and you continue looking for etiology because you think it might lead to a better treatment. But at the same time, you have to figure out how to live with it. And there's groups like the LGS Foundation, whether you directly have LGS or you have something that looks kind of like it, where you can find a community of caregivers who come up with all sorts of life hacks to live with this disease and are trying to aggregate resources to help. So that would be my advice personally. But I know there's periods, patients, like especially our family too, we would wax and wane and we'd like, we got to find the cause. And we'd be like, God, we're never going to find the cause. And we just do this sort of looping. But the science is catching up. And I do think knowing the etiology is important. Go talk to your doctor. We have about, even though we think from, the papers that we could find the cause, identify the cause in 90% of LGS cases, if you survey our community, 70% of them have no idea what the cause is. So the doctor stopped looking after, birth injury or stroke at birth, but the family doesn't really equate that stroke at birth with the thing that led to seizures that led to LGS. So it's important to know that.
Great. And that brings up one good question that just came in before we do the next talk, and that is, should the families fight for doctors or providers to give them an LGS diagnosis if the child generally fits the profile in order to get the services and treatments they need?
So do you want my personal or professional opinion here? So this is a really hard one, because I am a patient advocate and a mom, and I am a scientist. And I am of the mindset, to be honest with you, that if we are doing a rigorous scientific study, like a clinical trial or something along those lines on LGS, right? This is a scientific study. We should really be studying LGS. Okay, put the scientific study away. Let's live in the real world. I live in the real world. And the real world is that there's no reason to suggest that only LGS kids and Dravet kids should get Epidiolex and that will be effective for them. We were convenient populations to try those drugs in because we have big populations, but that drug is targeted still against seizures, not against anything unique in LGS or in Dravet per se. It's great that they worked in those populations, but why wouldn't they work in a kid with hypothalamic hamartoma, or a kid with DU15Q abnormality, or with another disorder, right? Or tuberous sclerosis is another one that it works in. So I think that there are times to look at the broader DEE community. And the reality of the situation is kids in our community all the time get the LGS diagnosis just so they could get access to something like Epidiolex or a new drug coming out or services. And this has been going on in the autism community. My kid doesn't have an autism bone in her body, but they always wanted to diagnose her with autism when she was young because there were services. And I cannot object if we're helping a child. I can object though when there's a study. And so I get in trouble for this answer, but the reality is we need to help these families, because the journey that we've been on is a hell that I have really very few words to describe. To really get into it. So.
Well, thank you. I think that was a good answer. A great answer. All right. Well, thank you again for that talk and kind of reviewing the importance of kind of getting to a syndrome. And of course, we've the first two talks have really brought up kind of the topic that I'm going to talk about, which is getting to the etiology and why that can make a difference as well, especially as we get into the world of precision medicine. And so that's what we're going to talk about now for the next 40 minutes, using Dravet syndrome, which is in fact a clinical syndrome, but talking about the value of its importance in understanding the etiology. So just real quick, I'll give you my disclosures. These are all companies that primarily work in the world of rare disease, and especially Dravet syndrome, which is why I participate with them. So as I said, our objective today is I'll introduce Dravet syndrome as a prime example of a developmental and epileptic encephalopathy that often has a known cause. In that, we'll discuss the underlying etiology that for most people with Dravet syndrome is an abnormality of the SCN1A gene. And then I'm going to spend most of the time reviewing how that understanding of the etiology can have very important impacts on diagnosis and management. So we've seen this already this morning. Dr. Worrell showed that, but always like to bring it up to remind everybody that we always begin by trying to figure out first when we see a patient, is the event in question a seizure or not a seizure? Once we determine that it is, we like to know what kind of seizure it is, which then works us to the diagnosis of epilepsy. And if the clinical features are present, an epilepsy syndrome, and then always looking to see if we can discover what the etiology is, because it can have significant impact, as well as diagnosing the syndrome. Having the etiology has significant impact on how we go about treatment. So we're going to talk about Dravet syndrome, and I'm going to start, just in case people are not very familiar with Dravet syndrome, just giving a brief overview of the condition so that you understand how it has a collection of signs and symptoms that ultimately help us make the diagnosis. So it was first described in 1978 and originally called severe myoclonic epilepsy of infancy, and then later renamed for Dr. Charlotte Dravet in 1989. As an example of how a syndrome may change over time, the initial criteria for this condition were that the patients would have a family history of epilepsy or febrile convulsions. They would have no previous history of disease, so they're otherwise very healthy before the onset of seizures. And seizures would begin in the first year of life as generalized or unilateral clonic seizures, so episodes where one side of the body would have kind of rhythmic jerking in the setting of fever. Later on in life, they would develop myoclonic type seizures and other types of focal seizures. While the EEG might be normal initially, they would develop abnormalities, including generalized spike wave and photosensitivity in the second year of life. They often would have normal development initially, but in the second year of life would start to have abnormalities in development, or at least slowing in development. They could develop other neurological signs at that time, were often very intractable to therapy, and all had some form of cognitive delays and often abnormal behaviors. Now, over time, more and more patients with Dravet syndrome were collected, and over time we realized that not everybody follows that exact pathway that was initially described. So in 2010, some changes to the description came. One is that we recognize that a family history of epilepsy or febrile seizures is a variable and not required for the diagnosis. The initial seizures don't always have to be generalized or unilateral clonic type, but myoclonic type and other focal seizures may arise. Importantly, the initial seizures are not always in the setting of fever. It was clear that atypical absence and absence status occurred very frequently in this population, with photosensitivity being a common trigger. Other neurological signs that were initially described are not present in all patients. MRI, of course, became more commonplace, and it was recognized that it's often normal. And while there is cognitive deficiencies or abnormal behaviors, the degree of this varies across the spectrum of the condition. So if we kind of walk through a presentation of a kid, as a provider seeing a kid and taking the history, we always like to begin at the beginning and work up to the present time, because my advice to people that don't have a diagnosis, have not really achieved a diagnosis of etiology or a syndrome, is to always revisit the story from the beginning, because what can happen when you see a patient with Dravet syndrome in the first 6 months of their condition may not be a clear diagnosis, but when you see them in the first 4 years of their condition and hear about the story all the way through, it may become very obvious what their syndromic diagnosis is or their underlying etiology. So in the first year of life, generally between the ages of 5 and 8 months, seizures begin, often in the setting of fever, but not always. As we said, they're clonic, generalized, or unilateral clonic type. They tend to be very long seizures when they do occur, often presenting as status epilepticus. As I said, the EEG is often normal, and many times kids are diagnosed as having febrile seizures initially, but these seizures will often recur within weeks to months of the initial presentation. As I said, other seizure types may appear over time, which starts to make it even more obvious that we're dealing with something beyond febrile seizures. These are things like alternating hemiclonic seizures. So the child may present once with predominantly right-sided shaking, the next time the seizure is predominantly left-sided. Generalized tonic-clonic, myoclonic, atypical absence seizures all begin to arise. And tonic seizures, while can occur, are rare in this syndrome. Between the ages of 1 and 4, these other seizure types start to arise. And again, the picture becomes more obvious. It's during this time that the EEG that was initially normal may start to show abnormalities like generalized spike and polyspike wave, and atypical absences are shown in these examples here. It's also during this time between age 1 and 4 where a child who was otherwise developing normally and on a normal developmental path, the development begins to slow. It may stagnate. In some cases, it may regress, particularly after very long seizures. It's during these ages that we start to see increased problems with inattention and hyperactivity and other abnormal behaviors. Now, what happens after that from age 5 to adulthood is a story that's really still being told as we understand what this condition looks like in adult ages, but we know seizures will persist into adulthood. They tend to less frequently be prolonged, but they certainly can still be prolonged. Seizures more often may occur in sleep, though again occur in the wakeful state. Cognitive delay will persist. Abnormalities of gait or walking arise generally after age 6, and we know that there's a higher rate of death specifically from SUDEP in this condition. So epilepsy is part of this developmental epileptic encephalopathy, but it's only one part. There's significant cognitive and behavioral issues, sleep issues, gait and orthopedic issues, feeding, social, autonomic, and of course, as I said, a higher risk for sudden unexpected death. If we explore those really briefly, cognitive development is both an epileptic encephalopathy and probably a channelopathy. And what that means is that some of the developmental abnormalities are indeed related to the frequency of seizures, the abnormalities on the EEG, but also some of the development may be secondary to the underlying genetic cause. So simply having the abnormality in the SCN1A channel, this sodium channel that often causes the disease, contributes to these developmental abnormalities. As I said, cognitive impairment is varied. So about a quarter of patients will have severe cognitive impairments, about 40% moderate, and the rest a milder cognitive impairment. And abnormalities in behavior, specifically hyperactivity and inattention, are very common in this group. Sleep is a huge problem with these children, with the majority of patients or parents reporting some type of sleep concern, usually with difficulty falling asleep and also transitions of sleep. So even if they do fall asleep, they then wake up and have a hard time returning to sleep. Over time, orthopedic abnormalities arise in a lot of these children, especially around the age 6 for most. It's characterized by what we call a crouched gait. So they have flexion at the hip, as well as at the knee and at the ankle. And they have a gait that is very shuffling, slower gait, sometimes difficulty getting started, difficulty changing environments or textures of the flooring or direction. Obviously, this gait is unfortunately not a very good gait as far as endurance, which is why many children with Dravet syndrome may need things like medical strollers or wheelchairs sometimes for long distances, even though they can walk independently. Gastrointestinal abnormalities are reported in the majority of patients, generally in the form of prolonged meal times or needing assistance with eating, sometimes with swallow dysfunction. And then other autonomic abnormalities, endocrine abnormalities, and immune abnormalities are reported in higher numbers of patients with Dravet syndrome. So that's the syndrome, and we can make that clinical diagnosis based on the history and what's going on with the kid, and we can certainly choose treatments as a result that are very useful just by knowing the syndrome. But knowing the etiology takes us one step further. So the etiology in Dravet syndrome for the majority of patients, not all of patients, is an abnormality in a gene called SCN1A. The diagnosis to get to this is made through genetic testing. often with epilepsy panels or whole exome sequencing are the most common things people use. And as I've said, about 80% of patients with clinically diagnosed Dravet syndrome will have an abnormality within the SCN1A channel. The majority of these are just a simple change in the code that makes the protein that then changes basically the recipe or the directions of how the sodium channel that goes into the cell is made, and you end up with a different function of the sodium channel, and oftentimes a function that's not good enough to do what it needs to do. My simple knitting example is that you think you have a pattern. When you have a pattern, you want to make a scarf. You're going down that pattern, you read it all the way through, and you make yourself a very useful warm scarf. For Dravet syndrome, many of these have a change in that recipe, a change in that pattern, where when they're making the protein and they get to that abnormality, it tells them to do something else, and it may say stop, don't make any more, or only make part of the protein. And then what you end up with instead is a very short and not quite as useful scarf in the knitting example, and that's where the condition comes from. So, great, you got a test, you got an SCN1A abnormality, so now you've got the etiology of your clinical diagnosis of Dravet syndrome. Who cares? What good is it to know that? Well, the first place it's good is it helps you know what it is, and it helps you know what it isn't. And so what are the examples of that? Well, first, it's important that everyone understand having a variant in SCN1A does not necessarily equal that you have Dravet syndrome, and having Dravet syndrome does not necessarily equal that you have a variant in SCN1A. And this diagram here is a good example, right? So in the gray, those are people who have a clinical diagnosis of Dravet syndrome. They meet those clinical criteria that we described in the first few slides. And as you can see, the majority of them will indeed have an abnormality within SCN1A as the cause. But over on the outskirts of this are people who bleed into that diagnosis of Dravet syndrome. They have a lot of clinical features that would be consistent with the condition, but in fact, they have other reasons. So STXBP1 or the GAB channels, or SCN1B or SCN8A, or maybe SCN2A. And the reason that's important is because the treatments for these conditions may actually be different. So, when we think about Dravet syndrome and we think about our immediate rules that we shouldn't be treating with sodium channel medications because that aggravates the seizures in Dravet syndrome, if they had that clinical phenotype but instead had an SCN8A or maybe a 2A mutation, it's possible that in fact sodium channel drugs would be better for those people. And in reality, what we find over time as we have collected more people with SCN8A, seen more people with SCN2A, PCDH19, for example, we realize that these are actually distinct syndromes in many cases, and we start to realize some differences that help us define these syndromes better. And I'll give you this example of PCDH19 here in a couple slides. So great impact on management, as I said, understanding what the gene abnormality is and how that gene abnormality impacts the protein will then lead to understanding what the treatment should be. So for Dravet, in the setting of SCN1A, we know we should avoid aggravators, which are seizure medications that work on sodium channels. So lamotrigine, carbamazepine, phenytoin, these are all examples. Doing this, we know, can be very helpful for seizure control. We understand that we can reduce the risk of status epilepticus, and as have been shown in slides Dr. Worrell from earlier today, we know we have better long-term outcomes if we limit the exposure to aggravating drugs. Understanding the gene may help us predict the course. Okay, so you come in that first year of life and you have some features that suggest maybe you have Dravet syndrome. Understanding the gene that may be responsible may help us better predict what to expect in the future. And a prime example is the PCDH19 associated epilepsy, which was commonly fit within the clinical criteria of Dravet syndrome for much time, until it's become really clear that it's actually a separate condition. And so in comparing and contrasting the two disorders, both present with seizures in the setting of fever. The difference is that Dravet with SCN1A are usually prolonged seizures, as I said, with status epilepticus, while PCDH19 often presents with clusters of seizures, so short seizures, but many of them over many days. PCDH19 occurs almost exclusively in females because of the way it is inherited, whereas SCN1A variants can impact both males and females. Tonic seizures are rare in SCN1A Dravet syndrome, whereas they're much more common in PCDH19. Developmental delays are present in both conditions, but more often on the milder scale in PCDH19 compared to SCN1A. And while sodium drugs we know should be avoided in SCN1A, PCDH19 doesn't necessarily have any clearly contraindicated meds. Seizure freedom tends to occur more frequently, or at least it's been reported more frequently, and some drugs like ganaxolone, for instance, might be more successful in that condition. So again, now we've got an etiology, and we've learned what it is and what it's not. But what's even better in understanding the etiology is an explanation of why the condition happens. What does that abnormality do that makes Dravet syndrome happen? And so we do understand that. We understand that the sodium channel that is abnormal in this condition is a channel that's highly expressed in GABA neurons. So in the simplest form, you've got two systems of importance in the brain. There's the excitatory system, which kind of creates electricity, and you have an inhibitory system, which job is basically to try to control that electricity so it doesn't get out, doesn't get out of hand. And the reasons for epilepsy, again, in its simplest forms, is either you got too much electricity or too much activation in the excitatory world, or you don't have enough inhibition in the GABA inhibition world. So for Dravet syndrome, the problem is the sodium channel abnormality in the inhibitory system doesn't work, and as a result, the inhibition doesn't work very well, thus leading to increased excitation and increased seizures. So when we know this, when we know exactly what the gene is that causes the problem, one of the great things we can do is develop treatments specific to that abnormality. And when you know that, you can develop animal models. And so you can develop mice, or you can take zebrafish, which has been done, and create a Dravet model. So you take these animals, you bring in the same kind of variant mutation in the SCN1A that you would see in humans. And then with these animal models, you can look at lots of different treatments. And so I think one of the great stories of Dravet syndrome is the use of zebrafish. Zebrafish are these very small little fish. And the great thing about them is when you compare them to mice, first of all, mice take up a lot of space in labs. They need a lot of care and attention. And fish are much, much smaller. They take up much less space, and you can have lots of them as a result. The zebrafish is one that in its first days of life, the skin is permeable. So anything that's in the water around the fish is absorbed into the fish. So it makes a very good model for studying drugs. Basically what they do is they take a zebrafish that has the SCN1A abnormality and Dravet syndrome, and then looking at those fish, test a variety of different drugs. And that's what Scott Baraban and his lab out in California have done, and identified multiple drugs that might be effective in this condition. So what's shown down here is this is basically, they have, each fish has a little aquarium petri dish basically that they swim around in. And what you can see in their swimming pathway is that when they swim very erratically, like you see in these where the yellow is throughout the circle, that is an indication that that fish is having a lot of seizures, whereas a healthy fish not having seizures often swims around in a nice kind of regular circle around the dish. And so they took these fish in dishes like this, having seizures because they had Dravet syndrome, and put thousands of different already available drugs into the water to see if any of them might be effective at controlling seizures. And they identified several drugs like clemizole, which was an antihistamine used in the 1950s that showed some effect. They used a medicine called lorcaserin, which is Belviq, was its brand name, was used as an appetite suppressant that had some success. and trazodone, a medication approved currently for the treatment of insomnia, depression, and anxiety. And all of these drugs have a somewhat similar mechanism of action, that they work via a serotonin pathway and kind of open the door to some possible therapies. Another thing you can do is you can develop, as we said, very targeted therapy, which is really the ultimate goal, right? It's great to develop therapies that might help us control the seizures, but the fact is that the condition is so much more than seizures. And as I said about the cognitive delays, where some of that is related to the EEG and the frequency of seizures, but some of it is related to the abnormality in the sodium channel itself. The question is there a way we can fix the problem, the sodium channel problem that causes the disorder? And fortunately, Dravet syndrome is really leading the way for that in development of targeted therapies, specifically two things: antisense oligonucleotides and something called viral vector therapies. So in my as best I can try to explain it very easily, the way the concept works is this. In Dravet syndrome, we all have 2 copies of SCN1A that make sodium channels for us. The problem in Dravet syndrome is that one of our 2 copies has an error in it. And so as a result, that copy does not make enough of the sodium channel. So effectively consider that people with Dravet syndrome have about 50% of the amount of healthy sodium channel that they need. So the idea with these therapies is that if there was a way to get to the good copy and to make more of the good copy occur, or at least keep the good copy from being broken down when it is made, we would be able to increase the overall amount of healthy sodium channels and hopefully get rid of the problem that is Dravet syndrome. When we think about these treatments, we want to think about a treatment that we can get to the neurons, the cells where the problem is occurring, and we want to not just treat seizures, but treat the other comorbidities. So antisense oligonucleotide therapy is one of those options. And so an antisense oligonucleotide is basically a piece of genetic information that binds onto messenger RNA. So the messenger RNA is made from the DNA, and it has to be read to make the protein. And in order to make it, it needs to be single-stranded. So when you attach this piece of additional information, you've now made it double-stranded and can in fact turn off pieces of it. So Stoke Therapeutics is a company that is investigating something they call targeted augmentation of nuclear gene output, or TANGO. They have basically identified portions of a messenger RNA that are called decay exons. And so this is pieces of information that even if it is a healthy copy, this piece of information, if it is included within the copy, will tell the body basically get rid of that copy. And so their idea is that if you can bind that and turn that off, you can stop the body from getting rid of otherwise good copies, and then therefore increase the amount of SCN1A that you have. So here's an example. As I said, you have one good version of SCN1A and one bad version of SCN1A. They make a messenger RNA. These messenger RNAs have decay exons in them that are bound to the good version and the bad version. And in general, what happens is those versions get thrown away that have the decay exons, only the other versions get through, and you end up with about 50% of each, and 50% just simply isn't enough. Now, if we take an antisense oligonucleotide and basically turn off that decay exon, what we end up doing is making all of the good stuff, and we make all of the bad stuff, but it's okay because the bad stuff doesn't work anyway. So we end up with an increased amount of the good version, hopefully that can then replace the loss and therefore take care of the disease. They have examined this approach in mice already and shown that it does indeed work. What these graphs show is that they've taken otherwise healthy mice, so mice that do not have the SCN1 abnormality, and they've taken mice that do have the SCN1A abnormality, and they've treated it with their antisense oligonucleotide. And as you can see, the amount of SCN1A protein that they make approaches what they would otherwise see in healthy populations. What's more important is that they showed a significant reduction in sudden unexpected death in these mice. So these mice, much like humans, are at risk for sudden unexpected death, and in fact the majority of them will die within the first few months of life if they have the SCN1A mutation of Dravet syndrome. And so what they showed here in the red line are those mice that have the condition not treated with the antisense oligonucleotide. And as expected, the majority of them died from sudden unexpected death. Whereas those that were treated here on the top line, almost every one of them survived. So that is just one of the first kind of examples of something beyond just controlling seizures, is that now an associated comorbidity has been reduced. So these therapies are currently being evaluated. There is a clinical study underway currently. The medication is administered through a spinal tap. And in addition to the clinical study, there are also some natural history studies going on so that we can collect the natural path of this disorder to compare to the treatment group to see where the change has been made. Another potential approach is looking at viral mediated gene therapies. The main difference here is that instead of dealing with the messenger RNA, we're dealing with the DNA. So this uses a virus that also carries basically a piece of information, not an ASO, but similar to, that can go and change the creation, basically taking and making more of the good version and less of the bad version. So that's pretty exciting. That now we know what it is, we know what it isn't. We have a target that we can develop animal models for, and using those animal models, develop very precise therapies. Other reasons why this is useful, knowing the etiology, is that we can understand the future a little bit better. When we have an abnormality, we can better predict recurrence, right? A common and a good question that a parent would ask, what is the chance that I will have another child with this condition? We know that 90 to 95% of SCN1A variants that cause Dravet syndrome are not inherited from the parents, so we call that de novo. We know that if it is in fact inherited from the parent, that it is inherited in an autosomal dominant manner, which means that if one of the parents has the same mutation, then there's about a 50% risk that another child would have that gene. What we don't know, obviously, is that if the parent has that gene and is otherwise healthy, or maybe has a somewhat different epilepsy syndrome, whether SCN1A will present as Dravet syndrome or a different phenotype in that other child. And then we can further kind of think about future pregnancies, because if we have a parent testing that is negative, it does not completely rule out the possibility that the parent harbors the abnormality. So for some people, the variant in the DNA will not be found in all the cells of their body and might only be found in the sperm or the egg, and that's what we call germline mosaicism. And so as a result, when you have this kind of testing, if you're told the parental testing is normal or negative, there is still some risk to have another child with a condition, and it's usually estimated about 1 to 3%. Next, we might be able to prevent severity, and I say one day because we really can't do that just yet. You know, it's difficult to explain for some people why one child with one SCN1A variant has a different appearance, a different clinical features than another child that has the exact same mutation, which suggests there's more to it maybe than just the one gene. There are other modifiers that may be changing things. But over time, as we examine more and more of these cases and understand their genetic etiology, hopefully we'll be able to understand the course of the disease over time and predict that from the mutation from the beginning. I think there's chances of potential anticipatory treatment. So for instance, with tuberous sclerosis, when we know that seizures and infantile spasms occur in the overwhelming majority of patients, can you treat with a medication before seizures ever start, like vigabatrin, and alter the course of not only the seizures, but development because you have done that? You imagine a day where you might be able to do these epilepsy gene panels as prenatal testing and see that someone does in fact have a known pathogenic mutation in SCN1A that we know causes Dravet syndrome, and could we do something right then and there with this ASO therapy or these viral vector therapies to prevent the disorder from ever occurring? And so, you know, maybe prenatal and newborn testing is something we could think about in the future. So all very exciting things. Obviously, to be able to do that kind of stuff, You need to know that you have treatments that truly modify the course of the disease, not just treatments that can, treat the seizures, but can actually change the course of how the disease progresses. So in concluding, Dravet syndrome, a prime example of how understanding the etiology will impact the ultimate treatment and the outcome. For many patients with Dravet syndrome, as I said, the cause is a genetic abnormality in the SCN1A gene, and understanding that etiology can lead to precision treatments, improving long-term prediction of outcome, anticipatory guidance, counseling. So a very exciting time, I think, in epilepsy that we have been able to get to this level of understanding of condition. So with that, I will say thank you. It's beautiful Cook Children's lit purple throughout the month of November for Epilepsy Awareness Month. I hope everybody is ready to celebrate for 30 strong days and beyond that, frankly. So thank you very much. I will stop and see what questions that we may have. All right, if there are any questions, feel free to throw them in. I'll see what I have here. I would have been reading throughout everyone else's talks, but I'll have to run back through here and read quick. See some of my great friends from Twitter. Good to see you all on here. Join us in Twitter. It's great fun. A lot of great information on there. All right, fantastic. Well, if there are not any questions, I am going to move on to keep us on time because it is time for the next one. So the next section we are going to have 2 speakers during this 40-minute period. And this section is all about getting to that genetic diagnosis. And I've got representatives from 2 different groups that are heavily involved in making those genetic diagnoses to talk to you about the approaches to do that and methods by which you might be able to get that testing if you haven't gotten it already. So our first speaker is going to be Dee McKnight. Dr. McKnight is board certified in clinical molecular genetics by the American Board of Medical Genetics and Genomics. She has more than 10 years of experience in genetic diagnostics field. And prior to joining Invitae, which is who she represents today, she was director of neurogenetics testing program at GeneDx, where she specialized in genetic testing for pediatric patients with epilepsy and intellectual disabilities. She got her doctorate degree at Penn State University and completed postdoctoral training at the NIH. While there, she was a research fellow for the National Institute of Dental and Craniofacial Research for 5 years, during which time she completed her board-accredited clinical molecular genetics training fellowship at the National Human Genome Research Institute. And we are super excited to have you here to talk to us about epilepsy genetic testing. Thank you so much.
Hi, thank you. I'm so happy to be here. This is really, these have been really great talks and have been so fun to listen to this morning. Can you see my slides and you can hear me okay?
Yes, I can.
Great. Okay. So today I'm going to talk about my favorite topic, which is genetic testing for epilepsy. Although the use of genetic testing has improved in recent years, we still really have a long ways to go. So currently it takes on average about 4.8 years for an individual with a rare disease to receive an accurate molecular diagnosis. And there are probably many reasons for this delayed diagnosis, but some of the more common issues seem to revolve around cost barriers, challenges with reimbursement, and an overall lack of comfort with genetics for a lot of providers. So this is where Invitae comes in. And as a leading medical genetics company, the mission is to bring comprehensive genetic information into mainstream medicine to improve healthcare for billions of people. So today I'm going to discuss how we've addressed barriers to testing for individuals with epilepsy. But first I want to discuss some of the reasons why it really is important to receive a genetic diagnosis if there is a genetic etiology for the epilepsy. And a lot of this has been discussed today. I just thought it would still be nice to summarize it in one place. So right now, there really are a lot of benefits to identifying a molecular genetic diagnosis for individuals with epilepsy, especially those with early onset epilepsy. First, we do find that there is a high diagnostic yield for individuals with early life epilepsy. So what this means is that when we do genetic testing on a group of individuals with early life epilepsy, or early life seizures, we tend to find a genetic etiology for that person in about 30 to 40% of individuals that we test. So this is pretty high for genetic diagnostic testing. Second, once we find the etiology, we may have helped that family avoid the diagnostic odyssey. So this can save the family money and time searching for an answer, which in turn can also help reduce overall healthcare costs. We are also finding that for a large number of individuals that have a genetic etiology identified, there can be changes in clinical management for their seizures. And we've already heard this in every single presentation today. So this is real, and it can be really helpful for the family. You can either prevent unnecessary studies or procedures or incorporate appropriate surveillance for anticipated symptoms. And then, of course, you can inform medications, either those indicated or contraindicated. Continuing, we find that a genetic etiology can help a family with planning, both to determine the recurrence risk for the parents and also for any siblings. Families might also find additional lines of support. They may benefit from finding advocacy or support groups that are centered around the same rare disease. Others find benefits from being part of the community of families that have similar concerns. And lastly, identification of a genetic etiology can open doors to clinical trials and other research studies. And we've already heard of some of the really cutting edge therapies on the horizon. And so this can provide early access to these valuable therapies and the cutting edge disease management, or be part of really valuable natural history studies. But altogether, we expect that these benefits will ultimately result in better outcomes for the individual and their family. So I wanted to briefly discuss common genetic testing methods that we use in clinical diagnostic laboratories. Test methods may depend on what or how much of the human genome you're interested in. So for some conditions, if there's a single disease that's associated with a very specific disorder that has a really clear clinical presentation, just testing one gene may suffice. But more commonly, the clinical presentation of the individual can be associated with a large number of genes, whether it be dozens or even hundreds. And a panel allows for testing many genes at one time. And panels are often designed around a broader indication, so such as epilepsy. Lastly, for patients who've already gone through diagnostic odyssey and still don't have an answer, or who have complex clinical presentations, a whole exome or a whole genome might be implicated. Genetic testing for epilepsy is often done using either a large panel and sometimes exome or genome. The most common methods for sequencing DNA is next generation sequencing, or NGS. And briefly, this is accomplished by extracting the DNA from the individual sample, usually blood, and fragmenting the DNA into smaller pieces. We then use what's called capture probes to bind and catch all the parts of the DNA that you're interested in sequencing. So this is almost like fishing, where you use a certain bait to catch the right fish. So the captured DNA is then sequenced, and the outcomes are small reads or copies of that DNA. Next generation sequencing allows for us to sequence many thousands of genes at one time. So most epilepsy gene panels utilize this technology. Whole exome and increasingly whole genome sequencing are common genetic diagnostic tests as well. So the exome, or WES, interrogates about 1.5% of the human genome. So this includes most of the 20,000 known genes and mainly just the coding regions or the exons of those genes. And this is typically done using the same capture-based NGS method I just described. Whole genome sequencing, or WGS, is just what it sounds like. So the whole genome is sequenced. That includes all 20,000 genes, plus all the surrounding sequence around those genes. And it really is important to point out that for the most part, we still do not fully understand that other 98.5% of the genome. So because of that, genome is not really clinically understood. So WGS, where the whole genome is analyzed, not just the coding regions, is really mainly done on a research basis at this point, although this will change, I'm sure, in the future pretty quickly. So we know that there are thousands of individual variants in our DNA, and that's what makes us unique. Once a technology is used to sequence the genes, either on a panel or exome, it's important to think about how is all that data analyzed. So how do we look at those hundreds or thousands of different variants in any individual sample and decide which, if any, of those variants are expected to cause disease? In other words, how do we do variant interpretation? And diagnostic laboratories who provide clinical genetic testing tend to follow guidance for variant interpretation from the American College of Medical Genetics and Genomics, or ACMG. In 2015, a set of guidelines were published in an attempt to further standardize the terminology in the industry and to provide recommendations that are applicable to a wide variety of tests and diseases. The standardized terminology recommended by ACMG included the terms pathogenic, likely pathogenic, a variant of uncertain significance, or VUS, likely benign, and benign. And they recommend using various pieces of evidence to assist in the classification of variants, and that I have these on the right. The evidence includes a consideration of the population data by looking to see if the variant of interest is present or absent in control databases. We also consider the type of variant that's being observed. For instance, is it a missense variant or a splice site variant or nonsense variant? And what's expected to be, and is this variant expected to damage the protein? Geneticists are also encouraged to consider the clinical findings of the individual that the variant was found in, and if there's any known molecular in vitro or in vivo studies that are conducted, such as enzyme tests, cell staining, knockout mice, or the zebrafish that Dr. Perry just discussed. And finally, in silico predictors of whether the variant is conserved in evolution or among similar proteins. Importantly, data is also shared among diagnostic laboratories through an effort called ClinVar. So this is a public database in which laboratories are encouraged to share their data. And this effort aims to increase information about any particular gene or variant for all laboratories, all providers, and really any individual to benefit from. So this is publicly available, and anyone can go here and see what information exists about any variant or gene of interest. But even with all this information, in many instances, there is not enough evidence to definitively distinguish if a variant is really pathogenic or benign. Every variant is generally either pathogenic or benign, and sometimes we're not able to decide, and so it's left in this VUS territory. And this is why it's important that the provider work with the laboratory to help gather other pieces of evidence that can help classify a variant. And this can include testing the parents to determine the phase of the variant or the variants. For example, is the variant de novo or spontaneous in the child in a dominant condition, or did the child inherit one pathogenic copy of the gene from each parent in a recessive disorder? Testing other affected or unaffected family members to determine if the variant is segregating with disease in a family can also be informative. And sometimes a more detailed clinical evaluation can help determine if the variant and gene are a good clinical fit for the individual. And lastly, in some instances, a further laboratory test, whether it be a metabolic analysis or an MRI, can help also determine if the gene finding is a good clinical fit. But it really is important that this is a collaborative process between the family and the provider and the lab to help with the interpretation of variants and unexpected results. So another interesting development in the last 20 years, or even really 10 years, has been the dramatic decrease in the cost of sequencing. So the decrease in sequencing costs has led to an increase in the overall sequencing of individuals, which has helped us increase our understanding of the human genome and the natural variation of the genome. And I'm gonna highlight this in two ways. So you've already seen this image about gene discovery, but I wanted to make a separate point about this. So as the sequencing costs have decreased, we've been able to sequence more exomes and genomes in different individuals, and this has led to this huge gene discovery in the last few years. But what I wanted to point out is that what this means is that what may have seemed like a large panel or even a comprehensive panel of genes that were tested maybe 5 or 10 years ago might not seem as comprehensive now, because in the last few years, we've discovered so many more genes. So while a lot of people may have had negative genetic testing 5, 10 years ago, it's possible that at that time, the actual gene just hadn't been tested in that test because we didn't know about it yet. So what this means is really a comprehensive test a while ago, maybe a few years ago, would look different to a comprehensive test today. A second benefit to our understanding of genetics as the sequencing costs have dropped is that we've been able to sequence the exomes and genomes of many individuals, both with and without disease. So this has provided us access to large cohorts of sequencing data from control individuals. In 2010, the 1,000 Genomes Project gave geneticists some of our first publicly available genomic data for 1,000 individuals. And then in 2014, the exact database was released from the Broad Institute, and the public now had access to exome data on 60,000 individuals. And this was a huge boost to our understanding of rare variants. Then a couple of years ago, the NOMAD database was released, also from Broad, giving us even more exome and genome data. So over the years, as more data has become available, variants that once seemed rare or even familial are now being observed in unaffected adults in these control populations and may now be considered benign. So this has led to many updated variant classifications and subsequently many updated reports over the last few years. So lastly, I wanted to share some information about our sponsored testing program at Invitae, and specifically the Behind the Seizure testing program. So this is a program that offers no charge comprehensive epilepsy NGS sequencing panel for individuals that qualify. Previously, as I mentioned, it could be challenging to get a genetic test for individuals with epilepsy. As recently as 2016, genetic testing was not routinely used by pediatric neurologists. The approach for this program was to offer a broad, comprehensive epilepsy panel at no charge to the patient. The goal here was to reduce the time it takes for individuals to receive a genetic test by removing the barrier of cost for that test. The impact has been significant. For example, individuals with CLN2 disease have experienced a reduced time to diagnosis by 1 to 2 years. And we've also seen the program evolve to include more biopharma partners and have also expanded the eligibility criteria for children with seizures. So on this slide are some of the statistics around the Behind the Seizure testing program. On the left are some highlighted statistics. We have issued over 10,000 genetic tests that were done at no charge to the family. We now have 10 different biopharma sponsors that sponsor the Behind the Seizure testing program. And we routinely test up to 192 genes associated with epilepsy using the Invitae Comprehensive Epilepsy Panel. That is what's part of the sponsored testing program. On the right is a figure that shows the number of individuals tested through the Behind the Seizure program in the last few years. This writing's really small. I'm sorry if you can't see it, but between 2018 and 2019, which is, oh, sorry, let me go back. 2019, 2018, we can see a huge spike in the numbers of individuals tested once the inclusion criteria was expanded to include all children under 5 years old with an unprovoked seizure. Then we see earlier this year that we further expanded the inclusion criteria to include any child under the age of 8 with an unprovoked seizure. And even though this year with COVID-19 and all the restrictions and access issues around medical care, we still saw an even greater number of individuals able to receive the no charge panel through the sponsored testing program. So I think it really does show that we've really removed a barrier to testing, which was clearly the cost and maybe the awareness of using an epilepsy panel for early life seizures. And so we're really proud of this program. Thank you.
All right, thank you very much. Thank you very much for that. I don't see any questions in yet, so I'm going to, since both of these talks are somewhat in the same topic, we'll move on to the other one and wait to see if there are any questions. Remember, if you do have any, feel free to put them into the chat and I'll be happy to ask them at the end. But we are going to go on to the next talk. And then our next presenter will be Anne O'Donnell-Luria, who is co-director of the Center for Mendelian Genomics at the Broad Institute at MIT and Harvard, and clinical genetics doctor at Boston Children's Hospital. Her research group at Boston Children's and the Broad focuses on improving our ability to interpret rare genomic or genetic variation and empowering the discovery of novel disease genes. She co-leads the Rare Genomes Project, a research study using genome sequencing to improve the diagnosis and evaluate the impact of a diagnosis on participants. Thank you so much for joining us today. All right, you are on mute. Let me see if I can get you unmuted. Whoops.
Sorry.
There you go. Now see if you can, let me make you a co-host to make sure you can share your screen. You should be good to go now.
Great. Can you see that?
Yes, thank you.
Great. So thanks so much for having me. I wasn't able to join the whole time because, as was mentioned, I am a clinical geneticist, and so I spent the morning in telemedicine visits until being able to join you. So I'm going to tell you today about the Rare Genomes Project, which is going to touch on a lot of the things that Dee actually mentioned. So we are, just to introduce the group, we're a group of genomic researchers dedicated to improving rare disease diagnosis. And we have a lot of experience with both genomic analysis and with variant interpretation. And as was shown in the last presentation, this study and this group is co-led currently by Heidi Ream and myself, and formerly by Daniel MacArthur, who started a lot of the projects I'll be telling you about, and has now moved to start a group back in Australia. But Heidi is was a senior author on the variant classification criteria, so very involved in that. And also Heidi and I and Daniel are the team that bring the NOMAD database to the larger genetics community. So I'm very involved in building a lot of the resources for the community. So that's there. So we are a really diverse team. We're a big group. We work on a lot of different projects. And so we have clinical geneticists, genetic counselors, including one or two who will be joining probably for this presentation, and also later in the day, you may meet them, Melanie O'Leary and Grace Van Noy. We have molecular geneticists who analyze the data, variant analysts, software engineers, bioinformaticians, and statistical geneticists. So I'm gonna just mention this briefly because this was also covered really excellently, where we're all looking for diagnoses for the same reasons that they have a lot of impact on people. And so they're important because one, like having a diagnosis prevents having a misdiagnosis. So you know that you're thinking about the right condition and not just sort of taking your best clinical guess. In a small number of cases and higher in seizures, probably there are medical management changes or recommended medications or medications to avoid based on a specific genetic or molecular cause. So it's really important to know. And then it's also just important to like have a community have a sense of what the future holds. Like a diagnosis isn't a prescription of this will happen or this won't happen, but it does give some guidance about what are kind of some things to expect, what will the path look like. And it can have a lot of help, be really helpful to the medical providers to work with families to figure out what things to worry about, what extra things to keep an eye on in terms of medical management and planning, and can help with other family planning for families. And then there's a lot of research going on, and hopefully there'll be more in the future. And so knowing what group or what molecular diagnosis and what research studies to participate in can also be really helpful from a genetic test. So if we tell you diagnosis is important, why isn't everyone having a molecular diagnosis? So there are a lot of cases we covered in the last talk also that there's not necessarily access or doctors realizing that we should do genetic testing. So much has been learned in the last decade or so that it used to be very rare that genetics would be helpful in seizures and other conditions. And now we know so much more. And so being able to offer genetic testing, not all doctors are really feel comfortable doing that. And then many times genetic testing is recommended, but insurance won't cover it because they'll say you don't know how it'll change medical management, and you don't know how it'll change medical management until you have the genetic test and know what the result is. So that can be kind of a circular, challenging argument. Some people are not diagnosed because a condition is not genetic. And so no matter how much testing you do, genetics is just not where the answer lies. And that can be hard to, like, we don't always have ways to know that. The way you figure it out is often after all the genetic testing, sort of not being able to figure something out. But there definitely are things that can look like genetics. There's also brain bleeds or other things that can cause problems that aren't, so they're not the cause is not always genetic. There can be multiple causes. And the third I would talk about is this where's Waldo. Like, so when we look at our genomes or our exomes, when we sequence any one of us, we all have thousands of variants, including over 1,000 rare variants. And so what we're trying to do is in genomic analysis is sort of pick out that one variant in that sea of benign variation that's causing the medical problems. And so sometimes it's in the data, it's in that list right in front of us, but we're just not yet clever enough to pick out which of the variants, which of the spelling changes it is. And so just interpretation still remains a major challenge that we're all working on. And the other is technical challenges. So not everything is easily picked up in the sequence of a gene, or there are still regions of the genome that are actually just very hard to sequence through because of some biology factors that make them hard to sequence, or it could be a deletion of a part of a gene instead of a spelling change in a gene. And so you have to be doing the right test to see the right genetic cause. And so there can be a lot of technical challenges built into this. So the Rare Genomes Project that I'm going to spend most of my time talking about is addressing access challenges, because it's a research study to help people access genomic testing. Analytic challenges, because we work really hard to improve methods and have a lot of expertise with analysis. And technical challenge, because it's genome sequencing, so it goes beyond panels or even exome sequencing and tries to capture some additional types of variation, although like we call it whole genome, but nothing is really whole. There's always parts we're unable to really see very well. So the Rare Genomes Project basically puts the latest advances in genome sequencing are changing medicine and should be more broadly available to families with rare and undiagnosed conditions. This is our kind of basic philosophical tenet. And so we have our website there that you'll see throughout this. So the project objectives are to help families find a diagnosis, to identify known and new molecular causes of disease, and to also share data rapidly to empower research. So we share our data in controlled access data repositories, and we've actually had researchers from other universities go in and access that data when they're trying new methods that, again, that sort of technical variation, the technical piece, trying to figure out new ways to identify variation missed by standard pipelines potentially. They've applied some of those and actually helped us make a diagnosis that we might have gotten to on our own, but it was even better and even faster by being able to share the data with other researchers in this controlled way. It was de-identified data, but still they were able to figure that out. So the project has a number of pieces. It has a recruitment arm. And so there things like this, I tell people about the project, as do many others involved in the study. We partner with a number of advocacy groups. We let clinicians, neurologists, geneticists, other clinicians know that the study exists and that people can apply. And I will say, actually, most of our applications come from just word of mouth from one participant sharing on social media or other ways that they signed up for this study or they got a result from this study, and we'll see other people to sign up and join. All that's required to apply is to fill out a survey online and share some information about the family. There's a remote video consent. There's no in-person visit as part of this. Our study team is located in Boston, but again, this is all done remotely. We collect a sample by mailing a kit. Mailing a kit. A blood test is done, and then we collect medical records and the blood through the mail. We analyze the data looking for causal variants. We try new methods and techniques. We collaborate and share data. And we do importantly return results when we find something. This is a research study, so it's research sequencing, but we take anything we find and we confirm that specific change in a clinical lab. And then we work with the participant's local provider to be able to return that result, and we help with follow-up questions. So who's eligible for this study? The participant basically needs to have a suspected monogenic condition, and so that's very important. I'm going to just mention this isn't an epilepsy study. It's a study for anyone with any condition that a doctor thinks could be due to a single genetic cause. Otherwise, people need to reside within the United States, and that's just because of regulatory reasons. And we are currently able to support English, and we've just expanded to Spanish speaking. Right now, if you go to our website, it's all in English, but we're going to be getting Spanish up hopefully in the next few months, but we're able to support Spanish through phone calls and walking people through applications, although again, that will get better over time. They have to have a medical provider involved in the care. It can be a pediatrician, it can be a neurologist, it can be anyone, but somebody that if we found something, they could put us in touch with a medical provider to be the one to help return that result so it goes into their medical care and medical system. So who is not eligible? So the first is unlikely to be monogenic, and I know that's potentially like a hard thing to sort out, so I've included some other slides where I've tried to frame that a little bit better. But every application is reviewed by a clinical team of genetic counselors and clinical geneticists to do our best to ascertain whether we think that the condition sounds monogenic. And when we can't tell, we'll even sometimes enroll people and review records from their medical doctor to provide more information about whether it sounds monogenic. There are occasionally things where it doesn't sound like genome sequencing would be the right approach. And we also, not an issue for I guess, epilepsy, but we don't work with cancer as one of the conditions, but almost any other thing that they think that doctors think are monogenic. So this is a graph I got from the Epilepsy Foundation website. And so it's showing that monogenic causes versus where genetics could still be playing an important component, but more as risk factors and multiple small genetic components adding up. For things that are monogenic, the genetic change is a strong genetic impact. It may not be 100% penetrant. It might not be that everyone with that genetic variant gets epilepsy or develops epilepsy, but that most people do. And so those are the kind of things that we're good at, that this study addresses, because the way the analysis is done is very family focused. And so it really focuses on the person with epilepsy or the person with any condition, monogenic condition, their parents and any affected relatives. And so we need things that studying the family we can really learn and understand. As you get into polygenic causes where they're larger genetic background and maybe one or two kind of moderately strong genetic factors is important, you need a different type of study. You actually need to study a lot of people with a condition like epilepsy and a lot of people who don't have it and kind of do a different type of comparison. And there are research studies like that. That's just not what we do. And so there are other options there. So I've tried to get a sense of some of the conditions, some of the monogenic conditions and what they are and how they're classified. I got it from this review. And so there are a number of kind of classes of epilepsies where I think Rare Genomes Project could potentially be a good fit. Things like infantile spasms or Dravet, I think it'd be very reasonable for those phenotypes to think about, for those presentations to think about Rare Genomes Project. Any of the early onset seizures and Lennox-Gastaut or LGS also. And so I've summarized this here. In general, the things that make you likely to be accepted to Rare Genomes Project if you apply with epilepsy as the presenting feature is onset of seizures within the first 2 years of life. It's not a hard and fast cutoff. I'm just like, that's the most likely to get accepted. Specific categories of epilepsy, or epilepsy plus other features, other birth defects or significant learning challenges or developmental delays. One of the nice things that people tell us about the project is that there are no age restrictions. So we are happy that we think a diagnosis, while it's great to make it early on, for people who are older, genetic testing wasn't available when they were young, and that is no reason why you shouldn't get these same options today. And so we will, and there's no age restriction on the study. And as I mentioned, we enroll both the presenting, like the person who signs up for the study or the parent who signs up their child for the study, along with the parents, and we sequence all 3 of those. If the parents aren't available, that's also fine. It's harder to do the analysis without the parents, but we will definitely still try. So I've described a lot how the study works, but I just wanted to recap that you basically go on to your computer, you sign up, we do a Zoom call to do the consent session where you have an opportunity to ask as many questions as you have about the study. You sign the consent form, and at that point you're considered enrolled. We then collect medical records. We ask for your help in that because that can be really tricky, although we also try to do it a little bit ourselves. We send you a kit to get your blood drawn, which you can do at your local hospital, or you can go to any Quest Diagnostics and we'll cover the cost of the blood draw as part of the study. You send that kit back to us. We also cover the shipping costs of mailing the kits. We get it, so it gets sent back, and then we send it for sequencing at the Broad Institute Genomics platform, where we do whole genome sequencing, so that's sort of most comprehensive test. And then we do analysis, and we have a whole team that works on the analysis. If we find something, we contact the family who signed up and say, are you interested in a return of result? This is a step that our institutional review board, our IRB, requires. It will say, to date, we have not had any family decline to pursue at this point. And so every time we've contacted someone, they've been very eager to learn more. And at that point, we do have to do a CLIA confirmation. So we have to do it, repeat just that for whatever we're trying to confirm and return. But it does get returned with a diagnostic report that can go into the medical record. And we work directly with the family's physician to be able to actually consent for that testing. They actually order it. We pay for it as part of the study, but then it gets returned right to your local physician to be the one to return that result to you. If you don't have a local physician, we have genetic counseling service that we can connect you with, and we also have a team of geneticists and genetic counselors, although we're not credentialed in every state, which is why we also work with a group that does have people credentialed in every state. So who is enrolling? We've had over 1,500 people enroll. They come from 47 states. We're really missing Hawaii, so we'd love to get some people, anyone from Hawaii. And Puerto Rico, we're hoping to also get some representation there. They're mostly from urban areas, as are most of the US. They're good male and female mix, and our age range for is 1 month to 89 years. So again, across the pretty much entire lifespan. And so diversity has been a challenge in the study that we're continuing to really want this to be a study that serves the entire community of people with rare disease. I just mentioned this it's not so much that they had negative prior testing, it's to actually just highlight that some people have had prior testing, some people haven't. I don't recommend doing a research study as a replacement for clinical testing. If you can access clinical testing, go for it. If you have clinical testing pending, because it normally takes just a few weeks to a few months to result, we ask that you wait for your result. And if negative, think about signing up for Rare Genomes Project. But if you can't access testing, or you've had testing and it's negative, go ahead and sign up. If you get diagnosed later, let us know, just in case it's at a point where we can kind of redirect things. But absolutely, clinical testing is always the way to go first. But if they're like, this research study is open to anyone, irrespective of what level of clinical testing you've had. And just a quick breakdown of the first 300 families analyzed. This is again across a number of phenotypes, so this isn't we'll focus on epilepsy or anything. There's a lot of neurodevelopmental conditions. There is some epilepsy in here, but it's a really mixed cohort, a group of families. We identify some kind of candidate in about half. For about a third of these, it's a diagnosis of either something in a known disease gene or a new disease gene that the family actually contributes to a publication for a new gene discovery for a new condition. We've returned 74 results to date, and we have a number of other cases or variants that we're tracking down and doing functional studies with different collaborators to try to learn more. We're not always able to find for some variants of uncertain significance. Sometimes we can't sort of figure out the next steps to go down, but whenever we can, we do really try to work with other groups and figure out as much as we can. And about half, despite our best efforts, still remain under analysis, and that nothing was found in the primary analysis, and we'll every year revisit them, and we're always bringing in new methods and new approaches, and so are hoping to continue to make progress. This is just one example of a diagnosis after a long diagnostic odyssey. So this now young woman who has a neurodevelopmental condition had testing, kind of grew up in the molecular era, so she had all the testing when it first came out. Altogether, she's had 18 genetic tests over the course of her life and had 132 genes tested. She actually never had whole exome sequencing. She ended up enrolling in the Rare Genomes Project kind of before, like in a time that could have been offered, but before that was done. We were able to diagnose her with this de novo variant in the gene KMT2C, which the family went on then to start a family-specific Facebook group for this disorder. It was really provided a lot of relief for her sister for starting her own family, and they're contributing to a publication. So they had a 22-year diagnostic odyssey and felt very relieved to get an answer. So the points of this study are to understand how genome sequencing can help with diagnosis, and the other is to figure out, to study the impact of a genetic diagnosis. So we do baseline surveys and we do post-diagnosis surveys. There's not a ton of surveys in the study. Those are kind of the two main points. And so we ask questions like how important it is finding a genetic diagnosis for you or your child, because again, both adults and children. And so for most people, they consider it extremely important. Even like actually for adults, they consider it extremely important, a little bit less for children actually. And then the rest find it very or moderately important. So again, as I think everyone on this call probably knows, like, and that's why you're here, is finding these answers is really critical. And so I just wanted to show you our homepage here. Again, that's the website. You can read about various things, but if you, anyone who wants to sign up, you just click this Get Started, and there's a video about the study, and the application is there. It does take us, we're a large team, but we work on a lot of different projects, and including a lot of resources for the community. So it takes about 2 to 3 weeks, at least, sometimes a little longer, depending on if someone's on vacation, to hear back after filling out an intake survey. I wanted to mention this one other thing, which I will do very briefly, is just the other category is people who have a variant of uncertain significance or a prior genetic test report that they are sort of uncertain about the result. And there's something called Genome Connect, which is a ClinGen patient portal, where you can register and basically share your genetic test report, and this group will reinterpret it and deposit it into ClinVar. And so for anyone who's had genetic testing like 5 or 10 years ago, or even less, who had a variant of uncertain significance, or even as it was mentioned by Dr. McKnight, like there are some things that we thought were the answer for certain people, and actually this past slide, this was a great story to check out in the Wall Street Journal, people who got diagnostic reports that said that there was an answer, but as we sequenced more people, we learned that these were common population variants. And so you can sign up for this and they'll actually reinterpret your data. And it's another way to connect with other people with the same genes involved. So it's just another resource out there for people who have variants of uncertain significance or old testing reports to make sure their result is still valid. So these are the two sites for the things that I've talked about today. And I just, again, wanted to thank everyone for listening, all the participants in our study, the whole team, and again, mention Melanie and Grace, who will be around later today. Thank you.
Great, thank you very much. Both of those talks, outstanding, and we're really meant to give families not only an overview of these, of the value and how genetic testing is done, but to give you an example of two different approaches to get access to testing. For some, it's maybe not been as difficult, but for many, getting genetic testing has been very difficult. So understanding that there are some programs out there that open up that access are really important. So either of you can answer these questions. There's two questions in here to pose to you. And the first, I think, is a really good one about, and I think this is as much for providers as it is for parents, but the question was, how concerned should they be about a result that is a variant of unknown significance or uncertain significance? I think the real question is, what is your advice as far as the process that both the provider should go through as well as the parent, in understanding what that result means and how they kind of work it out?
Yeah, I'm happy to take a stab, and then please feel free to jump in. I think that it's definitely important to look at the report. So often for VUS in which we think testing the parents could help resolve, there'll be a recommendation to do that. And in those cases, we should definitely continue with that variant interpretation by testing the parents. Possibly having, if the physician thinks that VUS is a strong clinical fit, contacting the laboratory and letting them know why they think it's a strong clinical fit, giving some of that overlap can help sometimes reclassify variants. So it is important to follow through with any of the recommendations that the lab has on a VUS. Because over the years we learn more, and as I said, variants often will be reclassified either to pathogenic, but more commonly to benign. Laboratories do routinely update reports, so it's important that you stay in contact with the provider, because the updated report will likely go to that provider just to see if there's been any changes. And then using the resources like ClinVar and Genome Connect can also help keep you in the loop with any of the most up-to-date data on any of the variants that you may have had reported that you're not sure if they've yet gone one way towards benign or the other way to pathogenic.
I'll just add, we all have variants of uncertain significance. So they're not like on their own a concern. Like if you didn't have any, that would be, we all have them. So I think it's great to register interest in Genome Connect. So if there are any updates, you'll get them. But otherwise, a variant of uncertain significance means that so it's between 10 and 90% certainty of pathogenicity. So it means like, it's like a huge window, meaning there's a 10% chance or a 50% chance or a 90% chance, like all those in there are basically where your variants of uncertain significance live. So talking to your doctor about, do they think it's on the higher side of that or the lower side, just to give you a sense of how much of an eye do I keep on this? You know, if you have a variant of uncertain significance and your doctors think it's like a lower chance, then you probably should think about, are there other tests you should do? Are there other things you should look for? Versus if it's on the higher side, it might be the answer and we just need more evidence, and that's just going to take more time and more people getting sequenced. So talking to your doctor and sorting out where you fall on that can give you a sense of what to do with it.
Great. So a second question that came in was from a patient who has a clinical diagnosis of progressive myoclonic epilepsy, specifically Unverricht-Lundberg disease, and has had epilepsy panel done that is negative. And their question is there other testing that should be done to help get to a diagnosis, given that obviously everything's negative otherwise, other than the clinical diagnosis?
I I think that's a great question for you, Dr. Perry.
So do either of you have any specific testing for that? I mean, my suggestion for people is a couple things. This brings up a couple topics of importance that you all brought up. First of all, is that if you have had genetic testing in the past and it was negative, keep in mind when your genetic testing was done, because a lot has changed. A lot changes very rapidly. An example I will give, just given that I talked about Dravet syndrome, is you will see people who have clinical diagnosis of Dravet syndrome and they had testing done, 10 years ago. And, it was great testing 10 years ago, but if you go back and look at it, maybe it only included sequencing, or maybe it only included deletion and duplication, and which means that it would have missed one of the other ways that you could have an abnormality to cause the condition. And so you have to go back and test it. So I see a lot of families who, will come to see me in clinic and say, yes, I've already had testing and it was negative for Dravet. The next question for the provider is always, let me see the results and understand what kind of testing you had done. So the same goes with this. You'll want to know exactly what the testing was that was included on that panel. Your provider can talk to these companies. They are, and these labs, they are great to work with. They will explain to you what they did and can tell you what the weaknesses of that test are and the potential to miss it. Disorders, for instance, that have like triplet repeats and things like that won't be picked up on these things, and you have to be aware of that. I remind people that people still have things like ring chromosome disorders and things that, again, will not be picked up on these kinds of things. So you have to really look at the testing and understand what has been done. And so that is on, that's on the providers, first of all. That is one of the biggest problems right now, is that genetic testing is becoming easily available, which is great. But easily available means lots of people order it, and means they don't always know what they got with the results. So and they don't necessarily always know how to interpret it. So that's why it's really important to look into it. The other mistake I see made commonly for people that get panels back that happen to have genes that really don't have so much of an epilepsy association, but might have some, but have an association with many other things, that the provider's looking for epilepsy, and when they see nothing epilepsy, they move on and ignore the fact that there's an abnormality. The most common one I run into is SCN5A, which is a mutation related to an abnormal cardiac condition called Brugada. And you will see people that get this testing and don't even note that that's on there and is important, and probably needs a cardiologist to at least do an evaluation. So you just get your results, look over them carefully, go through each thing, make sure we understand what is there, and always revisit, always. All right, those are excellent. We have got 2 more talks to wrap up this symposium. And so we have talked about syndromes, and we've talked about etiologies, and we've talked about how to get to those etiologies, and now you know what's going on. And probably the most important thing along the entire journey are the advocates and organizations that push for understanding and curing these diseases. And so our last 2 talks are going to be from two great advocates to help us understand how to get to the right care and how to get to the right support. So this first one will be from my good friend Marianne Meskis from the Dravet Syndrome Foundation. She has been with the Dravet Syndrome Foundation for a long time, stepping off the board to take the position of executive director in 2012. She is a very passionate advocate for Dravet syndrome community and has served in various capacities in that community prior to the inception of the Dravet Syndrome Foundation in 2009. In addition to her role at DSF, she serves on several epilepsy working groups, including the Epilepsy Leadership Council, the Rare Epilepsies Network, as well as several advisory panels. So Marianne, thank you very, very much for joining us, and look forward to hearing what you have to say.
Thank you. Let me pull my screen up. And whoops. Can you see my slides okay?
Yes, yes, we can.
Perfect. Okay. Well, thank you so much for having me here today to talk about getting to the right care. This is a big topic, I think, for so many within the rare epilepsy community. It's nice to meet everyone. I'm Marianne Meskis, the Executive Director of the Dravet Syndrome Foundation. And as Dr. Perry mentioned, this is an area that's very near and dear to me because I have a 20-year-old son with Dravet syndrome. So your first step in getting to the right care is really getting a diagnosis. And we've heard from a lot of speakers before this, some different routes that you can take to get there. But even though it's gotten easier in more recent years, this can be for many families a prolonged and a difficult journey. And I think this quote really nicely sums up what so many of us experience as we're working towards getting the diagnosis and then moving forward from there. And that's nothing about the rare epilepsies is simple, not the diagnosis, not the daily care, and not the long term. So to share a little bit about our family story, my youngest of 3 children, Elliot, was born after a healthy pregnancy, no complications. He was meeting all of his milestones. And at about the age of 6 months, he had his first seizure. It happened in the middle of the night, and we estimate that it was about an hour and 20 minutes, although we're not quite sure how long he was seizing before we found him. We did have to go to the ER. The ER doctors were very perplexed as to what was happening. They were finally able to get it under control. And then the next morning he woke up to his baseline. And so I think just not having that experience, the ER doctors wanted to dismiss it as a febrile seizure, even though he had not had a fever of any significance. They told us, most likely this is not going to happen again. They sent us home, and we were hopeful that that was going to be the one and only time that we had to deal with this situation. Unfortunately, about a month later, he had his next seizure, and then they became more frequent, never lessening in severity and actually worsening. And then in addition, he started to have multiple seizure types. And as you might remember from Dr. Perry's presentation earlier on Dravet syndrome, his presentation was very textbook. But unfortunately, since Dravet syndrome is a rare epilepsy disorder, we had not run across any healthcare providers that really understood the syndrome or knew how to diagnose it. So in our situation, I'm sure for many of you as well, it really often falls to these patient families to keep fighting for answers. And so, there's some strategies that I would like to introduce that may help you get to a diagnosis. Chances are, if you've been on this journey for a while, you're already doing some of these things. But I would certainly encourage you to track the symptoms that your child is experiencing. For us personally, as well as a lot of families in our community, they use Seizure Tracker. And if you're not familiar with that application, it has an extensive diary. And so you can not only track seizures, but a lot of other information that will be important to healthcare providers, just in maintaining your child's health and well-being. One of the things that we've always really appreciated is that there's the ability to actually video the seizures. In Dravet syndrome, there's some unique seizure types that present. And again, before diagnosis, when I would try to describe these to our neurologists, it was difficult for them to understand what I was trying to explain to them. So having those videos is very helpful. Along with these videos, there's also data and graphs, and you can actually send these directly to medical professionals, which is helpful. I think it's also really important for you to keep your medical records up to date. For our son, even though he was so textbook Dravet syndrome, he did not receive a diagnosis until he was 4 years old. But thanks to a lot of the records that we kept, the neurologist who was able to diagnose him was able to go back and look at his onset, his seizure types, and that really helped her to confirm his clinical diagnosis once she was able to evaluate him. So having those years of notes really just showed what a textbook case he was. And we were one of the ones that was fortunate in that, he is now 20 years old, was not diagnosed till 4. So he was diagnosed shortly before the advent of the first commercial test that was available to check for an SCN1A mutation. And it was really by pure chance that we were able to get a clinical diagnosis. And I do think that if we hadn't kept pushing, that perhaps he could still be walking around with an idiopathic epilepsy diagnosis at this point. You should never be afraid to get a second or third or a fourth opinion. We were very fortunate early on. As his seizures got worse, we had gone to the leading children's hospital in our area, and they did a very thorough evaluation of our son. But because of the way Dravet syndrome progresses, his MRI was normal, his EEG was normal, he was still developmentally on track. And so they really just thought this was an idiopathic epilepsy that he would probably outgrow. But his neurologist that we were assigned to really became frustrated in the years following his initial intake because everything that she was trying was having the opposite effect on him. And one of those reasons was that he was being given drugs that were contraindicated for his syndrome. So even though she was pushing us for a second opinion early on, we were somewhat hesitant because we liked her. She was open and honest with us and worked well with us. And thankfully, it was her pushing and her taking the time to present his case at a round table with some other neurologists that finally led us to a diagnosis. In hindsight, I think I should have been more aggressive, but I think, you know, it's such a heavy burden that you're carrying for these children that we were just happy with the state we were in and having a medical provider who was working with us rather than really pushing forward for that diagnosis. And then keep advocating for your child. I know firsthand that most days you are so exhausted between doctor's appointments and fighting insurance and just that 24/7 care that your child needs, but you really do have to be your child's voice and just keep pushing for answers. And keep trying even when it feels like you've exhausted every single avenue. I know this is a very difficult journey, but a diagnosis at any age is so beneficial for the patient and the family. It can open doors to new treatments or even clinical trials that can offer some relief. And I think a good example is what's happened in the Dravet community. That is a rare epilepsy. We've been very fortunate in the last few years to have 3 new treatments get full FDA approval with an indication for Dravet syndrome. And so for our families that have that diagnosis, they have a new pathway of different treatments they can try. Once you get the diagnosis, you are at the beginning of this new journey. Even though you've been on this journey, now you have a little bit more of a pathway to follow. And so I would suggest that first you really want to educate yourself about the condition, and whenever possible, connect with any type of advocacy group or patient families that you can find out there. You know, some of the disease states that have been recognized for a longer period of time have larger advocacy groups built around them. But for many of these new gene mutations that have been discovered, there's at least a Facebook group that you can connect with. It's these patient families that I think will be so vital in your journey because they'll be the ones that can share their personal experience and what they've gone through. We see in our online support groups that, you know, 24 hours a day, families are available. If a family jumps on with a concern or a question, everyone's willing to share their experience, ask questions, and that advice really becomes vital as you're trying to kind of figure out what your next steps are in this journey. It's also really important that you find the right specialists, and quite frequently either the advocacy groups or these other patient families can help you on that journey. As it being a rare disease, frequently you might come across healthcare providers who you end up being the one educating on the syndrome and having to make sure that they take whatever precautions are appropriate for your child's health and well-being. So it is important to do your best to find those physicians who do understand the syndrome, or at least who are willing to work with you and are willing to learn what the best way to treat these diseases are. Also, it's really important to look into state programs and services for your child. I mean, this can be an exhausting journey, and you're going to need help, even though you might not want to admit it in the early days. We often tell our families if they can't find another family in the area that could give them advice on state programs and services, we often refer out to the ARC as a starting point. They're always very well versed in current changes to state waiver programs, and we've heard in the past that their staff is very receptive and willing to help our families. And you really do need to, as I mentioned previously, you need to connect with others who understand what you're going through. And also, if you come across these advocacy groups that are in existence, most likely they're going to have tools and resources that can help you on this medical journey. To give you a little bit of background on the Dravet Syndrome Foundation, it was started in 2009, and it came about because myself and 3 other parents had met online. We're from all across the US, and we were really frustrated that there were not only a lack of resources for families that they could, for instance, share with medical professionals, but there was just no research happening in the field. So at that point, we decided to start the Dravet Syndrome Foundation with the idea that we were going to try to fund at least one research project. We've been very discouraged that if you were to look at NIH funding at that time, if you looked at epilepsy in general, there was very little funding available. So by the time you worked your way down to a rare disease like Dravet syndrome, there was just nothing happening. And we were very fortunate within that first year. We were able to award our first research grant. And then it was really the power of our community and the drive of our community that pushed the organization forward from there. I think as many of you have felt, you receive these diagnoses and there's no direct treatment path and you can feel very lost and very overwhelmed. And for those of us who started the foundation, as well as the other families that have gotten involved, there really is this sense of empowerment that you're doing something not only to benefit your child, but also those that will come after you. And so I think when you're feeling most lost, it's very powerful to have that opportunity to do something to make a difference. So as the organization grew, we had given our first research grant of $100,000 that first year. Now, 10 years later, we've been fortunate to award a little over $5 million in research grant awards. And that really is the hard work of all of our community members making that happen. And we've also been able to really talk and listen to our population to find out what are the things that they need to help them in their day-to-day life with this. And so as a result, we have designed a bunch of programs that we feel kind of attack all of those different issues our families are dealing with. We have different support options, such as our online support groups that are private for parents only. We also have a lot of educational opportunities that include our annual Day of Dravet workshops and our biennial conference. We also do a series of webinars every few years just to have materials available that are up to date for families to reference or share with their healthcare providers. We've also tried to make sure that we help families with some of the financial burden that they experience, and we offer patient assistance grants, which cover durable medical goods and educational equipment for families. These are items that typically would not perhaps be covered by commercial insurance, but are still very much needed by our families, including things such as cooling vests or adaptive strollers, iPads, things like that. And then also to give our families other opportunities to connect, we have a few programs, which is Caregiver Connect, which allows our family to talk about the stress they're experiencing. Birthday Buddies, which is a program for our patients with Dravet syndrome to sign up for to receive a special package on their birthday. And then our Super Siblings Club, because we recognize that there is so much going on for our families, and siblings often end up facing a brunt of the stress that happens in the household and often feel placed on the back burner. So I just can't stress how important it is to help find your people. I know Kari's going to be talking about this more in her upcoming presentation, but I think this alone is one of the things that will really, really help you on your medical journey. I also wanted to talk a little bit about caregiver burden. And when I say this, I don't want you to think that I'm implying that our children are burdens, but there really are a lot of responsibilities and around-the-clock care that come with caring for a child with a rare epilepsy, and it's often mentally and physically exhausting. I think things feel more complicated and heavy when we're in the middle of a pandemic, so it's all the more reason why you need to find your people and connect with them. The rare epilepsies deal with so much more than seizures, and this little word cloud was actually made for a presentation that was specific to Dravet syndrome, but I really think it crosses over so many of our disease states. You know, for our families, it's not just the frequent seizures, it's the chronic infections and the gait issues, the behavior issues, delayed speech, and certainly something that hangs heavy over our community is SUDEP. We have an estimated 20% mortality rate in our children, and about half of that mortality rate is due to SUDEP. So, you know, a lot of our families are terrified to put their children to bed at night, just unsure if they're going to wake up in the morning. This caregiver burden is so significant, and there's so much stress and fear. And then in addition to that, there's a lot of financial and emotional burdens that come with living with a catastrophic seizure disorder. We've heard from our patients, you know, that there is that emotional burden that really impacts, you know, not just the patients, but also the families. And now, especially during the pandemic, we're hearing more about families feeling even more isolated or misunderstood than ever before. And so, you know, I think as an individual, or as each of us as individuals, we really need to acknowledge this and accept that this is difficult, this is hard, and we shouldn't be afraid to ask for help and find the resources that we need. I think a lot of us, myself included, just feel like this is our battle alone and that we need to work through it and just make things work. And in the end, we end up doing more damage to ourselves and our loved ones than accepting help and trying to find those resources. So when we look at the caregiver burden, I'm sure you can all appreciate, you know, when we look at this care situation, we are often the experts in our child's care. We're the ones that are performing medical tasks, coordinating care, advocating for our children, and sometimes educating the medical professionals that we deal with. And this day-to-day impact for our caregivers is pervasive in all aspects of their lives with no areas untouched. We hear from families that have had to leave a job to become a full-time care provider, have had to drop out of school. They comment on their physical and emotional health. At the end of the day, they're so exhausted that they don't make the choices to eat right or exercise. They're just so obsessed on trying to do all they can for their child and their family. But it's this round-the-clock care that's never going to stop, and it's going to continue through the life of the child. So it's really important to try to find that balance. A lot of our families have had barriers to support and care services. These can include socioeconomic factors or language barriers, but what we hear most frequently is just at the end of the day, families are too tired and they don't want to argue or navigate one more thing. We hear a lot about the financial impact on our family, along with those high medical costs. Like I mentioned earlier, it's very common for one parent to have to leave their job in order to become the full-time care provider for the child. And in most states, there aren't any programs that help support that or pay the caregiver directly. So that really impacts the overall financial stability of the family. We also hear all the time about the sense of loss that our families have. I know I personally, for many years, kind of lived in a perpetual state of grief for what I had expected Elliot's life to be and what our family's life would be. And it took me a long time to work past that and recognize that he was happy and he was in a good place with his medical care, and to be thankful for that. As I mentioned before, our families talk all the time about how socially isolating this disease can be. A lot of our families early on in having to deal with these prolonged seizures tried their best to avoid any type of seizure trigger. And so they're hesitant to put themselves in a situation where the child might be in a place of overexcitement or might be exposed to an illness. And they really cut back on any type of social event that really weighs on their mental well-being as well. And so they need that outlet. And as previously mentioned, the needs of the child really impact the entire family, including siblings, and changes the interpersonal dynamics that go on in that family. We've heard from our families that a lot of times siblings will be withdrawn or feel that they're not heard or understood, or that they matter as much as the child who has the disease. And so it's really important to recognize that, and again, try to find resources that will help the family as a whole. And I think, you know, for me, this was very hard, but it's true for all of us, that we need to remember that it's never a matter of when we need support. It's really what support do we need at this part of the medical journey that we're on. And there are some days you'll feel stronger and feel that you have it under control, and other times that you'll feel overwhelmed. And that's okay. You just need to come to a point where you can find that balance and use the support that's available to you to make it through. I had, oh, did it pop up? There we go. I had wanted to share this graphic with you. It comes from a paper that was published by Dr. Ann Berg out of Northwestern University. And she had done a really nice study on the seizure burden in severe early life epilepsy. And one of our families had given me this quote before, that it's not post-traumatic stress disorder, it's ever present. You never leave the battlefield, it's constant traumatic stress. And I think this graphic so nicely kind of sums up the complexities of what we all deal with, you know, starting with the seizures and then dealing with the unpredictability, the frequency, the severity, you know, building out from that. It's very common for us to have to cancel plans or reschedule things. School gets missed, work gets missed, just overall sleep is disrupted. And then there's the terror of the severity of the frequency. You know, do we need to administer rescue medications, or is this going to be another trip to the hospital? How long will we be there? You know, how will we balance the needs of the other children in the household? And really, with all of those things happening, you feel under that total stress and pressure where it's difficult to let go of that constant fear and anxiety. You feel bad for not doing enough. There's the pressure on all of the family members, depression, loss of hope. And again, our families quite often cite just being exhausted all the time and that they're surviving and not thriving. And in addition, it impacts your ability to make plans that you know you'll be able to follow through on. You're constantly battling other things such as issues with advocacy or insurance. Healthcare management is another thing where there's so many multiple appointments and specialists that you're trying to balance. And then, of course, you know, dealing with, is this medication working for my child? What are the impacts of that medication? What are the side effects? Could we be getting better seizure control? What do we do about the issues we're having with eating or sleeping or behavior? And it's just really a large burden to carry. So as you get to the point of diagnosis, or even on your journey to diagnosis, you're going to need to assemble a healthcare team that really understands the complexities of your child's condition. It's going to be really important for you to find the specialists who understand the disease and the associated comorbidities and who can really deliver that appropriate and comprehensive care. You know, as an example, one of the things that the Dravet Syndrome Foundation has done is that we have 2 different tools available for our patients. One of them is Find a Doctor, and it's a listing of healthcare providers with experience in Dravet syndrome. And many of these physicians have been actually recommended by patient families. And then we also have a listing of comprehensive care centers. And these centers are those that not only understand that diagnostic criteria of Dravet syndrome, but also all of the associated comorbidities and the need for the appropriate medical care around those comorbidities. The other benefit to being seen at one of our comprehensive care centers is that these centers are frequently involved in studies and clinical trials, and they tend to be knowledgeable about new treatments and cutting-edge research. For rare epilepsies that perhaps don't have these tools in place, I would suggest at least looking for a level 4 pediatric epilepsy center. The staff there is going to be more familiar with rare and complex epilepsies, and they're going to be able to offer more extensive medical treatment. Also, most level 4 centers can offer complete evaluation for epilepsy surgery and surgical procedures. I think it's really important too that you don't forget, as you bring this team together, that you are the most vital part of this healthcare team. You're really the one that knows your child the best. You know what is typical or atypical for them. You know what's happening on a daily basis with their care or any significant changes that are happening. So you need to recognize that you really are part of that team. It's going to be important for you to have the appropriate support and information you need. Some of that is going to come from the healthcare providers you see, but again, often the experience from other families who've been on the same medical journey is going to be so important and will really help you when you're trying to make some difficult medical decisions. It helps to have that guide as to what has worked and hasn't worked for other families. Of course, you're going to need to be willing to have very hard conversations. You know, unfortunately, I wish I could tell you otherwise, but there will be very difficult choices that you'll have to make. And the best way to decide what to do is to have all that information available at that time that allows you to make an educated choice that you feel good about. So don't be afraid of bringing things up to your physician that you might have read or heard about from other families as you're trying to decide what your next treatment pathway will be. You know, rare epilepsies are rare diseases, and that means that a particular rare epilepsy is a disease that affects fewer than 1 in 2,000. So for a lot of the healthcare providers you come across, your child might be the first patient that they've seen with that disease state. So you might have to be the one that is educating them about this disease. That could mean bringing in brochures or papers, directing them to a website for an advocacy organization. But again, I think if they are willing to work with you to assure the best quality of care for your life or for your child's life, then it's important that you help educate them in whatever way you can. And as I said before, it's really important for you to acknowledge that you're living in a constant state of stress. And I don't think at any time you should feel bad if you have to lean in on your healthcare team or friends and family when you're having a hard time managing this disease. If you're working with the right team, they'll be very receptive to this and will do their best to help you. And then for those who might be in the Dravet syndrome community, I just wanted to quickly introduce you to our staff. All of our staff and our board members either have a child with Dravet syndrome or another rare epilepsy, and or unfortunately they've lost a child to the disease. So for us, this is a very personal battle. And we just recently added Dr. Veronica Hood, who's our research coordinator, Jamie Cohen, our program director, Jenny Gallo, our administrative coordinator, Misty Reed, our campaign director, and Wendy Fry, who does our family engagement. If at any time you have any questions, we would definitely welcome you reaching out to us. Even if you don't have a Dravet diagnosis at this time and you're just trying to connect with the community, we would be happy to try to do our best to connect you with the people that can help you. So I'm a very strong believer that the more we can unify our voices and come together, really the greater the impact is going to be for the entire rare epilepsy community. So thank you so much for being here today.
Excellent. Thank you very much, Marianne. Just a great organization. Love working with you guys. And it's just a wonderful, wonderful talk. I'm going to give just a few seconds because Mike from SynGap Research just wanted to say a few words.
Yeah, thank you very much, Dr. Perry. I just wanted to say thank you to Marianne for everything she's done for us. When our kid was diagnosed, I crashed the Dravet Syndrome Roundtable 3 years ago, and I knew nothing, and Marianne just told us what to do. And 3 years later, we're about to have our second roundtable because, like everything, when my board asks me what to do, I just say copy Dravet Syndrome. You were about to redo our website, and it's going to look a lot like theirs. She's an inspiration, and she's been so generous with her time. I just wanted to take a moment to thank her for all the help she's given us, and I'm sure countless other organizations.
That's really kind of you. Thank you, Mike. And really, we have built off of the support that we found from other organizations as well. I think so much that it's a team effort, and I'm glad we could help you and maybe make the path a little quicker.
Excellent. Well, one of those other great organizations is up next. So this is going to be our last talk of the session, and I'm happy to welcome Kari Rosbeck today to talk to us. She joined the TS Alliance in June of 2001, becoming president and CEO in November of 2007. She's been involved in nonprofit fundraising and volunteer management for more than 30 years. During her tenure as president and CEO of the TS Alliance, we established a comprehensive research program to foster collaboration with industry and academia to move treatments for tuberous sclerosis forward in an expedited fashion. The Unlock the Cure research strategy focuses on key points along the drug discovery path and also serves as a capital fundraising campaign with more than $12 million raised for TSC research since August of 2011. So welcome, excited to hear what you have to say about the advocacy organization and how once you have the diagnosis, you want to get to the right support system. Thank you.
Great. Thank you so much, Dr. Perry. I will just share my screen. And just want to make sure everybody can see that.
Yes, we have it.
Perfect. Perfect. All right. Well, thank you for the opportunity to be here. Following Marianne is always a chore because she speaks so beautifully from her heart. And I'm so grateful to be able to work with Marianne and with Tracy Dixon Salazaar from the LGS Foundation very closely. What I want to do is share the TS Alliance story and our antidotes for getting to the right support as a way for anybody who's dealing with a rare epilepsy or with epilepsy to get to the right supports. So first of all, the Tuberous Sclerosis Alliance was founded in 1974 by 4 amazing moms around a kitchen table, something you certainly hear a lot about in our epilepsy organizations. We've become an internationally recognized nonprofit dedicated to finding a cure for tuberous sclerosis complex while improving the lives of those affected. And like many of our sister organizations, we accelerate research, improve access and quality of care, support and empower our constituents, educate and mobilize to increase awareness, and really build and strengthen our organization. Sorry about that. As you've heard in earlier talks, TSC is a genetic disorder that causes tumors to grow throughout the body. Actually, TSC can be diagnosed in utero because of the presence of heart tumors. And more than one heart tumor, 2 or more, creates a 99% probability of a diagnosis of TSC. And it's because of that that we have begun the first preventative clinical trial for epilepsy in the United States, because we can detect TSC even before the onset of seizures. And we are very fortunate, and we hope that this clinical trial that we have will be able to be replicated in other rare epilepsy syndromes. TSC is the leading known genetic cause of epilepsy and autism. It impacts about 1 in 6,000 live births, 50,000 Americans, and more than 1 million people worldwide. I'd say the first step in your journey, and Marianne laid out some things so beautifully. I don't want to replicate the things that she said, but you will see a lot of similarities. First, people often look to the website, and I hope that that's true for those that are dealing with rare epilepsies. If there is a website or a Facebook group, that's the first place that you should turn. We've really spent a lot of time building an information library on our website. And when you're newly diagnosed, there's actually a section on our website that is just for you. And it has 3 main parts to it. Get support now, which includes access to our full-time advocates, introductory brochures, and a consensus guidelines physician letter. So we want to give you all the tools and resources. And for any of the groups out there that ever want to replicate, or any epilepsy family that would like to take a look at our resources, please. I think that they are helpful for everybody. 5 things you need to know. So in TSC, for instance, it's a complicated disease, lots of comorbidities. We are here to assist you and have a catalog of resources. We want to make sure that you get to good healthcare, because that's essential for treatment and management of TSC, and have a listing of our recognized TSC clinics on our website. We also put together a helpful letter for you to share the diagnosis with your family. Sometimes it's very hard to find the words to share what does this mean. And so we put together a helpful letter to do that. And as Marianne beautifully said, it's really important to connect and talk to somebody who has walked this journey. And we have lots of links to peer support, which I'll talk about a little bit later. And then also, as Marianne did a great job of talking about choosing a healthcare provider, we, in addition to our clinics list, have a physician referral list in areas where there may not be a TSC clinic. And working with the TSC family, put together a TSC screening tool for what are the questions asked to find the right clinic for you. These are just some of the resources, a catalog of resources that we provide to families. This is under our Individuals and Families tab on our website. We have 2 full-time advocates that are available to talk with families after they receive a diagnosis of TSC, and many organizations have similar programs. Really, this is to get you connected immediately to the care and support and peer support that will help you on your journey. Social media is another great way to connect to get immediate support. Facebook private discussion groups mean that you have access to folks 24 hours a day, because it's incredible that there's always somebody there to help you. Instagram has become more of a major connector, as has in our community Inspire, where people can go on anonymized and ask very difficult medical questions. And then Dr. Perry, you're the king of Twitter. That is another social media channel where people are connecting. At the TS Alliance, we also have a community programs team, and many other epilepsy organizations do as well. So not only do you have somebody you can talk to within the organization, but there are groups of different volunteers, community by community. Our community programs team is made up of our Director of Community Programs, April Cooper, our Senior Associate Director of Community Programs, Gail Saunders, Shelley Meitzler, who's the Community Programs Manager East, and Julie Scroggins, the Community Programs Manager West. Together, they manage our volunteer branches, which take place in 37 locations across the United States, actually covering all 50 states. Our community alliances are our ambassadors out in each community. They provide educational programming, peer support, raise funds and awareness, and are there for anybody who is new to the journey of TSC. Also within our Community Alliance program, our peer-to-peer support program, which is called TSC Connect. And we have 408 volunteers across the country that are really there to support you. So not only do we have 46 Community Alliance chairs and vice chairs, we have different programs within the Community Alliance. One is a dependent adult transition resource coordinator. So if you are the parent of a child that is transitioning from school age into adulthood, we have trained 32 volunteers in 26 states, because we all know that things are different state by state, that will be there to guide you through that journey. We also have 10 adult regional coordinators that work in 8 regions. TSC is a lifetime disease, from folks that live very independently to folks that don't and will be dependent on their families through a lifetime. Our adult regional coordinators are there to help our independent adults as they continue to manage the journey of TSC for themselves. We also have a Future Leaders program. So for young adults with TSC and their siblings, they provide peer to support to that really important young adult group. We also have trained 35 parent education mentors. So we all know that trying to get care and supports through school systems can be a maze. And so not only Dina Hook, our Vice President of Support Services, provides IEP services, but we've trained 35 parents across the country to be able to attend IEP meetings in 26 states with our families. And then finally, of the 64 TSC clinics across the United States, we have clinic ambassadors. So they'll go to clinic or they'll be available from the clinic to answer any questions about care, support, resources in the local community, but they're very connected to the clinics. We also have tentacles all around the world. There are 38 TSC organizations around the world that work together as a coalition called Tuberous Sclerosis Complex International, or TSCI International, and there's an awareness day every May 15th. And we also have very special and formalized partnerships with 6 of these organizations around the world and work together on support programs in each of their countries. The TS Alliance also provides support through digital resources, and I know that other epilepsy organizations do something similar. We have a magazine we publish twice a year. We have bi-monthly e-newsletters. We have a TSC alert that goes out specifically for researchers and healthcare professionals. TSC Now, which is our monthly podcast series, and TSC TV, which is a series of webinars and videos that you can find recorded on our website. All of that offers additional support resources to really help you on your journey when trying to navigate the many manifestations and comorbidities with TSC. Tuberous Sclerosis Alliance also developed an online educational platform called TSC Academy, which really helps to lift the scientific knowledge of our community. There's a primer on TSC 101, an introduction to research and funding, and then the advocate's role. And if anybody in any epilepsy would like to take the course, I think it's really helpful in understanding research and your role as an advocate. Finally, like many of our epilepsy sister organizations, we offer conference series. This year, of course, it's virtual. Usually it's in person and in regions across the country. We do this in partnership with the Lange Foundation. Lange is a disease that affects mainly women. with TSC and through spontaneous lymphangioliomyomatosis, but caused from the same gene mutation. So we do these conferences together. Next year, we're planning a 28 series of webinars around 4 main topic issues: TAND, transition workshops, which we'll make available to all epilepsy organizations, clinical trials and research updates, and then life stages of TSC, including refractory epilepsy throughout a lifetime, and what are some strategies to employ. And then, of course, these are all free 1-hour Q&A, recorded and available for anybody to view later. As Marianne mentioned as well, we had a robust response to COVID-19, put together a resource page that included resources for TSC medical professionals, an FDA drug shortages and supply chain updates, COVID-19 FAQs, partnered with the TSC community to develop resources focused on their needs, including 68 webinars on relevant topics such as schooling from home, or anxiety, or remote behavioral interventions, and very importantly, self-care. And I know that Marianne talked a lot about caregiver burden and the importance of self-care and seeking support. We also partnered during COVID with many of our advocacy partners out there, and held 5 town hall meetings, including one that we co-hosted with Dravet and LGS on accessibility to treatments. And all of these are recorded and are available on our COVID-19 page. Lots of organizations hold national or world conferences. Our next one is scheduled to be in 2022. Could be virtual, could be moved to 2023, just depending on what is happening in our world. And then I just wanted to share, there are so many resources out there for support for those in the epilepsy community. And I've listed just a few of them in their websites, and I know that this is being recorded so that you can go and seek out these incredible resources in the future. Child Neurology Foundation has lots of information on their website, as does Cure Epilepsy, Danny did for SUDEP, obviously Dravet and LGS. Our sister organizations and partners, the Epilepsy Leadership Council that you heard mentioned earlier. We're also part of a coalition called the Infantile Spasms Action Network, with lots of important information on infantile spasms. The Rare Epilepsies Network, Seizure Action Plan Coalition, which we just announced yesterday with the website coming soon. And Marianne also mentioned Seizure Tracker, which is a very important partner of the TS Alliance, being founded by parents of a child with tuberous sclerosis complex. And then there are also federal resources out there for support by both the Centers of Disease Control and National Institutes of Health. And really coming together, we will cure all of these epilepsies, but it's going to take us working together. And I'm really happy to be a resource to anybody seeking information or any organizations that are seeking to partner. So thank you.
Thank you very much. That was outstanding. Again, another fantastic organization. You know, advice I give to parents that contact me kind of asking about providers, especially when they're dealing with rare disease, is that, you know, as Marianne said in hers, you know, your doctor may see only one kid with that condition. And it's absolutely, you know, great to be able to go to a doctor that has seen lots of that condition, and that would be ideal, but that's not going to be possible for everyone. So I encourage people to, you know, it's great to seek that out, but the other thing to seek out is a provider who is willing to learn. And willing to learn means to, you know, if they don't know the answer, which they will not know all the time about these rare conditions, be able to look it up, be able to partner and be willing to partner with these advocacy organizations who often will be able to find the answers for them very quickly or much faster than they might on their own. Both of these organizations have great systems where, I mean, even, you know, if I have a question about one of these conditions and I see them frequently, you send it in, it gets sent out to the rest of the network, and you get a lot of responses from other people and their experience. So it's just great stuff. I did have one question come in particular to TSC, and they just wanted to know where they find access to TSC Connect.
Oh, they can contact Dina Hook at dhook@tsalliance.org. Or there is a map under the Engage tab on our homepage. It will lead you to a map of each state, and if you just click on your state, there'll be a list of TSC Connect volunteers in your local area.
Excellent, thank you. So we've got a little bit of time. We reserved a little time at the end just in case there were any other questions that came up from the group. So if you do have any questions for any of the speakers, feel free to put them in the chat. Most of the speakers are still connected, it looks like. And if they're not, I'll certainly try to get your questions to them. One question that came in asked if anyone has seen genetic abnormalities associated with genetic abnormalities on genetic testing associated with Julian syndrome, or also known as eyelid myoclonia with or without absence epilepsy. And so I will say, from my standpoint, the answer to that is yes, there are reports of some genes associated. CHD2 is one that is frequently reported. There are, of course, some case series of GLUT1 deficiency. GLUT1 deficiency presents with early onset absence epilepsy. So whether or not that is actually absence or eyelid myoclonia with or without absence syndrome, not sure, but that's one of the things to look at. So there definitely are some out there. There's not a gene that is associated with all the cases of Julian syndrome, but there have been some associated. As far as the rest of the day, the original schedule is going to be a little bit different. I believe the original schedule that was published on the website said that there was going to be an hour of Q&A that actually involved me, but my clinical duties today do not allow that. So I am going to be heading to the hospital a little bit to do some work. So we're not going to have that session, but there is apparently a dance party at 1 o'clock, and that will occur again without me, but nonetheless, apparently is going to occur, that the Epilepsy Awareness Disneyland folks have been working on. So if you're interested in that, feel free to return at that time to this Zoom room. Let's see, we do have a new question here that I'll look at. So the question is, with respect to Dravet, what are your thoughts on the new drug Fintepla? Well, my thoughts on the new drug Fintepla is that it is an exciting treatment to have added to our box of treatments for this condition. It is a drug that has no doubt shown significant reduction in seizures for kids with this condition. In the phase 3 trials, it was an average of about 70% reduction in seizures, which is outstanding. We actually kicked off Epilepsy Awareness Month here in DFW last night with a story on NBC after the Cowboys-Eagles game on one of my patients, actually, that entered the trial for Fintepla and has now been seizure-free for 3 years after starting that drug. So, you know, definitely a nice addition to our collection. And you know, as Marianne said, we have been fortunate to have multiple new treatments come the way of Dravet syndrome in the last few years, and still more in the pipeline, which is just really exciting. All right. Are there any other questions from any of the attendees before we wrap this up? One more follow-up question to that about Fintepla, which is, does it have fewer side effects than Depakote? Well, first of all, in fairness, it's not Fintepla versus Depakote, so it's difficult to compare side by side from a side effect standpoint. I will say from a side effect standpoint of Fintepla, it has some of the common things you see with any seizure drug. Any drug that works on the brain has some potential of, you know, sleepiness associated with it, though that was not really frequently a problem. Other common things like nausea, vomiting, constipation, those are all common things we see in many drug trials. And all those things were reported, but not to a huge amount. The things that are most important to look for that particular drug are appetite loss. As you probably know, the drug was part of a drug used for weight loss and appetite suppression in the past. So it's a logical potential side effect. So keep an eye out for that and weight loss, though most children that have appetite suppression did not have significant weight loss when they used the drug. There's also that drug has a program called a REMS program, so you have to get echocardiograms on it before you start the drug, and every 6 months, because the drug in the past was associated with abnormalities or causing abnormalities of the cardiac valves, heart valves, as well as causing pulmonary hypertension. In the phase 3 trials, those were not found. There's been over 5,000 echoes now and more than 3 years worth of study, and those have not been found when used at this dose for epilepsy. So that's very reassuring. However, as part of the drug use right now, you'll still have to get those echoes because we need to make sure in a real world setting that is true, that those findings don't happen. So a little inconvenience, I would say, but in exchange for what is very good control for many people, probably worthwhile. So another question related, still related to this topic, which is some of Dravet syndrome patients, particularly adults, are on antidepressants. And so what do you recommend if they will be starting fenfluramine? So in this case, they're on Zoloft. So the reason that's important is because this drug fenfluramine acts via a serotonin mechanism. And so you have to use caution when you use other drugs that have similar mechanisms of action, the monoamine oxidase inhibitors, the SSRIs, triptans for migraine, ondansetron for nausea and vomiting. These are all medicines that work on that same system. And so you have to use caution with that and be aware of that because it can precipitate something called serotonin syndrome. So does it mean you can't use the two together? I mean, it can happen. I'll tell you, if I do not have any experience in using them together to tell you, you know, how likely problems are to arise, because during the trials it wasn't allowed. So we're now into the real world where we can use those, and I've definitely used, you know, like Zofran, ondansetron's a medicine we commonly use, and I've certainly used it with kids now that are outside of trial and not had any problems. So it's one of those things. Anytime you add a medicine that particularly interacts, you need to add it a low dose. Be aware of the adverse effects. Keep an eye out for it and titrate. So not an absolute contraindication, but you got to use great caution. So yes, there was one question from earlier for Dr. Worrell before she got off, and it was in particular just asking if she had any cases of startle epilepsy in her practice and whether it was linked to any particular genetic conditions. And I'll tell you, fortunately, I have the bat phone to Dr. Worrell, so I'm able to get in touch with her and get a response from her. So let me find where she sent that to me earlier today. Here we go. So her response was that startle epilepsy, as you call it, is basically it's a reflex epilepsy, and the stimuli that bring on that epilepsy can be different depending on the patient and the conditions. Commonly, light is one of those things, but some people have sensory-induced stimuli, such as just sounds or being touched, can also stimulate the epilepsy. So startle epilepsy or stimulus reflex-induced epilepsy in and of itself is not a syndrome, but it can be seen with different etiologies, specifically certain lesions of the brain in particular areas. For instance, reflex-induced sensory epilepsy, if you have abnormality within the primary sensory cortex, that's a place that you have higher likelihood of having that. She said in her experience, no specific kind of genetic abnormalities to associate with that, but as far as treatments, benzodiazepines and valproate appear to be the most helpful meds in her mind. All right. Any further questions? Great. Well, I want to thank all the speakers for joining us today. Yes, this would have been a lot more fun if we were at Disneyland, and we're now able to go ride some rides and have a good old time like we did last year. Hopefully we will be able to do that again next year. If any of the speakers who have not been to this conference before out at Disneyland, I encourage you, if you get the opportunity, do attend, because it is great fun. It's a very good conference to be at. But I thank everyone for joining us today. Thanks to everyone who stayed on and listened to all the talks, and enjoy the rest of Epilepsy Awareness Month. Goodbye, everyone.